an introduction, a general overview. We're going to look at the prevalence of mental health conditions, some risk factors, some protective factors, and then I'm going to highlight some specific conditions that we should be on the lookout as family physicians for, and then prevention strategies, and of course, we're just going to wrap things up. So we're going to start with the basics. So world estimates as of June 2023, based on WHO, 311,447 people in the world. 970 million persons are struggling with mental illness or substance use disorders. 1 in 4 people will be affected at some point in their life. 14.3 or 8 million deaths per year is attributed to some mental health condition, and the prevalence of all disorders has increased by 50% between 1990 and 2013. And that's not even accounting for COVID. Numerous studies show us the link between mental illness and chronic diseases, as well as the increased morbidity and mortality when diagnosing a mental illness. How does this overlap with adolescence? So adolescence, as defined by the American Association of Pediatrics, is a period from age 11 to 21. It represents a period of cognitive, behavioral, emotional, and social development. It serves as the bridge between childhood and adulthood. And they highlighted that it needs specific focus because of the unique changes that occur and the implications on brain development, puberty, sexual development, gender identity, emotional health, and mental well-being. Mental health problems during adolescence can have implications for adulthood, and it can actually lead to lower life satisfaction, as well as poorer health-related quality of life in adulthood. So how common are we actually talking? 301 million people are living with an anxiety disorder in the world. And again, this is pre-COVID numbers because we still are crunching numbers post-COVID. Of that 301 million, 58 million are children and adolescents. 280 million people are living with depression, including 23 million children and adolescents. 40 million people experience bipolar disorder, and people with bipolar disorder are at an increased risk of suicide. 14 million people experience eating disorders, and almost 3 million of those are children and adolescents. 40 million people, including children and adolescents, are living with a conduct or a dissocial disorder. We are also seeing a rise in the number of neurodevelopmental disorders, including intellectual disability, autism spectrum disorder, and attention deficit and hyperactivity disorders, amongst others. Also, let's bring special note to the prevalence of PTSD, as well as other mental disorders that we see in areas of high conflict. So Ukraine, Palestine, and look at our general population, how many of our children are being traumatized on a day-to-day basis. So it's quite prevalent. Within the Caribbean, the State of the World's Children 2021 report revealed that approximately 60 million adolescents between age 10 to 19 live with a mental disorder in Latin America and the Caribbean. Anxiety disorder is the second leading cause of disability among 10 to 14-year-olds, and the numbers are increased when compared to earlier studies. And to highlight, within Jamaica in 2012, Prof. Abel et al. Found a depression rate of 4.5% among 3,000 high school students. And this was in 2012. This was before our drive to bring light to mental illness. So if we were to repeat this study today, I'm sure our numbers would be increased. So what I've tried to do is I've tried to structure things, because rather than breaking each condition down, we know that from a pathophysiological basis, there are certain risk factors and there are protective factors. So we're just going to discuss them across all the conditions. So in looking at the risk factors, we have a genetic predisposition. We know that there are some conditions that are genetically linked. Schizophrenia, for example, bipolar disorder, depression, anxiety, ADHD. All of these conditions have been shown to have multiple gene loci that have implications for the genetic transmission of these diseases. So your family history plays a significant role. If someone in your family, especially a first-degree relative, has one of these conditions, there's a strong likelihood that this child or these children may develop this condition. We also have to look at environmental risk factors. So it's the argument of nature versus nurture. ¿Por qué no los dos? It can be both. You can have environmental pressures that exist within a system that can predispose or perpetuate the development of mental health conditions. And we are looking at family structures, school structures, and community structures. So for example, within a family structure, if you have high amounts of interfamily discord, if a child is witnessing abuse, that child is at an increased risk for development of mental health conditions like depression, like anxiety, emotional dysregulation, personality disorders, schizophrenia. And the premise holds true across the spectrum. So if you are having dysfunction within the family, if you are having dysfunction within the school, vis-a-vis bullying or extensive pressure for academic performance, or extensive pressures from the community at large that demands uniformity or conformity, or prevents people from truly expressing themselves and being who they are, it can result in a risk for the development of multiple mental health conditions. And then we talk about biological factors, separate and apart from genetic factors. We know that during adolescence, we are looking at development of neurochemistry and hormones. Dr. Wright likes to speak about the developing brain, and it's very true. The literature holds true. The prefrontal cortex, which is the seat of our executive function, the seat of our personality, and the seat of good manners, is still developing well into the point of 25 years old. During this adolescent period, we are awash with hormones. It creates emotional lability. And because we lack that prefrontal cortex component of our brain, we are unable to separate and be able to objectively assess a situation. That is why adolescents and teenagers are so impulsive. The concept of consequences, for example, is sometimes lost on them. It's that typical teenage syndrome of, I am unconquerable, nothing bad can happen to me. The problem becomes, because of this impulsivity and because of this brain development, as well as these hormonal changes, it can lead to a mismatch between what is actually going on, which is why you see a lot of impulsive behaviors and emotional dysregulations within adolescence. So for example, you will see within the literature, adolescence is one of the peaks in the bimodal distribution of depression that we see very well because of the changes in hormonal levels, 1, and 2, the brain still being under development. So it's not all bad. We have some good. The protective factors. Supportive family and peer relationships, always helpful, reduces stress within the psyche and allows for development of the person holistically. We also have an increase in access to mental health resources. We should all know by now that every major clinic in every single parish has access to a mental health clinic. There are dedicated child guidance clinics within each parish, and in some parishes you have more than one. Within every major hospital, there is access to a psychiatric service, whether it is a primary psychiatric service or a consultation liaison primary psychiatric service. And in almost every single parish, there's access to private psychiatric care if we want to go that route. So mental health resources are available. This helps us to identify early and to treat early and improve our prognosis for these conditions. We also have access to NHF. Majority of our medications are subsidized under the NHF, and this is protective for us. We can also have the development of healthy coping mechanisms. We speak about the emotionally aware and the emotionally competent physician and family, gentle parenting mechanisms to encourage children to be able to safely process emotions that may be confusing for them. So rather than acting in or acting out, we can have a healthy discussion to help begin to process these emotions. So when a situation becomes overwhelming, rather than isolating or turning to something self-destructive or self-harming, we can have a conversation. Mom, dad, doc, I don't feel good. And part of the problem is at certain points in your life, you are not able to articulate these thoughts. And that's okay. The onus falls to us to help our children and our adolescents understand what is going on and to sometimes lend our experience and to give words to help to nurture them to grow so they can understand and name these emotions and claim these emotions and tame these emotions. So let's get into why we are really here. The specific conditions that we're looking at today. We have some very common ones, and these are the ones that I'm choosing to highlight today. Depression, anxiety and related disorders, attention deficit and hyperactivity disorder, eating disorders, substance use disorders, self-harm and suicide. Depression, or basic rundown. You have 9 symptoms of depression: depressed mood, anhedonia, changes in your sleep, which can be an increase or decrease in the amount of sleep, changes in your appetite and or weight, which can be an increase or decrease, fatigue, but more commonly in children, irritability, excessive and inappropriate feelings of guilt or worthlessness, psychomotor agitation or retardation, recurrent thoughts of death, dying, self-harm, or suicide, attention, memory, concentration impairment. You need 5 of these 9 symptoms for 2 weeks or longer to diagnose a major depressive disorder or a major depressive episode. But just because you don't have all those symptoms doesn't mean you can't have a depressive disorder. You can have a persistent depressive disorder. No, based on the DSM-5, for adults, it is 2 years or longer. For adolescents, it's for a year or longer. And we're looking at 4 of these 9 symptoms. So if a child is talking about feeling sad, feeling low, feeling down, and it's not persistent and all-encompassing, it doesn't mean that it's not a depressive disorder. It can be persistent depressive disorder, which is a low-grade depression almost. It is a persistent low state of mental well-being, and you are having other symptoms associated with it. Why do we care about this? Self-harm, risk-taking, and substance abuse among persons who have depression is very common. And this is from an update from UpToDate, where they collated data from across the resources. Parents often have concerns about side effects of medication and can it be safely and effectively treated? And this is always a challenge that we have. It is very difficult to look at a parent and say, your child may be suffering from depression or living with depression. And we have to weigh risks versus benefits. People are very hesitant about psychiatric conditions, first of all. We are more hesitant about psychiatric medications. We need to be able to have these conversations. We within ourselves need to be comfortable having these conversations, because I will be frank with you, there are times when I have children and I am very hesitant to start medication, because medication have side effects, but we need to be able to have these conversations to begin with. What we do know from extensive studies is that psychotherapy, medication, and other measures can alleviate symptoms and help children and adolescents to succeed in school, develop and maintain healthy relationships, and feel more self-confident. And at the end of the day, these are the metrics that we most usually associate with adolescents. What is their performance or relationship level at within the home? And what is their academic performance? And yes, depression can lead to academic impairment, not just because you are depressed and you are not functioning at school, but the second symptom of depression, anhedonia or amotivation, you lose the drive to be interested in school. Another symptom, the cognitive impairment, where you have the memory, attention, concentration impairment. If you are in class and you are trying to learn, but your cognitive symptoms are very much active and you literally cannot remember anything, you are going to be seeing a fall in these grades. And we are going to not be able to pick up what it is until we start thinking more broadly. Now, the million-dollar question, should we start antidepressants in children? There is a risk with antidepressants in children. Oh, I saw something on TV, the commercial said it may increase the risk of suicide for children when they start this depression. It's not recommended for children under the age of 18. Here is something to think about. Although it is not clear that antidepressants cause suicide in children and adolescents, depression can cause suicide. And this is what the meta-analyses of these studies have shown us. Is there a clear link between the use of antidepressants and an increased risk of suicidal behavior in children and adolescents? Some studies say yes, some studies say small, some studies say no. What we do know is that untreated depression can cause suicide, and that's what we want to avoid as much as possible. So, how are we going to assess and treat it? Start with a history. It starts with being able to have that conversation and do a mental status examination. We're looking for our red flag symptoms. Are they blunted? Are they restricted in their affect? Do they just not seem as expressive? Are they having slowing in their thought process? And the red flag symptom, are they having suicidal ideation? You can also have the presence of severe depression that can present with psychotic type symptoms. So we have to take a full history and examination. We also need to rule out a medical cause for these conditions, a complete metabolic profile. Is this a vitamin deficiency? Is this low blood count? Is this something else that can present with signs and symptoms of depression? Thyroid disease, for example, notorious for causing it. We may not be able to remember, or we may be uncomfortable asking some of these tricky questions. And I understand it and I respect it. God bless a screening tool. Love them. And they are useful for multiple reasons. Reason one, they are objective. There's no pressure. You can say to the person, all right, these questions may be a little intrusive for me to ask. We can hand you this questionnaire and you can fill them out in your own time. They're very straightforward, and it is you and a piece of paper, and you're just being honest with yourself. You circle, you tick, and you just see, does this apply to me? Yes or no? And if it does apply, how much does it apply? There are multiple screening tools available that have been internationally validated for use. Some of them include the Patient Health Questionnaire 9. You have the shorter version, which is the Patient Health Questionnaire 2, or you have the extended version, which is the Patient Health Questionnaire 15, the PHQ 15. You also have the Beck's Depression Inventory, and you also have the Hamilton Depression Rating Scale. All of them are available online for free, and they take about 5 to 10 minutes. Person can fill them out quietly, and you get back a response. It is usually very useful because, especially if a parent is in the room when you're interviewing their child, they don't want to answer truthfully. However, if a child is just ticking on a piece of paper that is outside of parental influence, you may get a truer response. And it has a very good sensitivity and specificity for depression. The other advantage of these is that you can use it as a metric for your treatment. So for example, I use the PHQ-9 quite frequently in my office. I had a client come in 2 months ago. On intake, everybody fills out a PHQ-9 and a GAD-7. International guidelines now recommend everybody over the age of 18 get screened for depression and anxiety. I'm here for it. Patient's PHQ score 9 was 23, which is severe depression, and that's okay. Patient was assessed, started on medication. I had them come for follow-up yesterday. We had several follow-up sessions in between, but I saw them again yesterday. After about 2 months on medication, and it is specifically done this way because antidepressants take about 2 weeks to start working, and your maximum effectiveness is at 6 to 8 weeks. At the 2-month mark, my patient's depression score went from 23 to 10. Subjectively, she felt better. She could tell me all the things that had changed and had improved. But when you can have her fill out a questionnaire again, and you can say, this is where you're starting, and this is where you are today. She literally wept in my office because she knew she felt better, but she did not realize how bad she was before and how well she was doing now. So it's very good for objectively assessing a patient and tracking patient response to medication, because what we also know, if at 6 weeks you're on this medication and your scores have not changed, this is not the medication for you. We can change. We have options. Now, when you are going the route of medication, before we write the prescription, let's just ask the questions for psychosis and bipolar and related disorders. We don't want to give a patient who we've missed with bipolar disorder an antidepressant, lest we convert them to a full-blown manic episode. We do not want to give a patient who is frankly psychotic an antidepressant because we're not treating the actual symptoms. Now, some people will say, do we have to give medication? No, we don't. Psychotherapy is recommended as first line for mild cases of depression. Some parents, some patients are hesitant to start medication. Doc, I don't want to be taking tablets. I don't want to live on the tablets. That's reasonable. We have the recommendation for psychotherapeutic interventions. There's individual psychotherapy, there's play therapy for younger children, or there's family-based interventions as needed. And these are all available here. So you can tailor your approach to what your patient and your family and you think is necessary. Now, specifically for medications, SSRIs have been the most studied and used. Fluoxetine, citalopram, escitalopram, all of them are available here. Fluvoxamine, not available in Jamaica. Paroxetine and sertraline are available for Jamaica. Fluoxetine has been more widely studied than other SSRIs in children and adolescents. Side effects often improve quickly, usually within a week to 2 weeks, but may include headache, abdominal pain, diarrhea or nausea, sleep changes, jitteriness, agitation, sexual side effects, or a tendency to bruise. And yes, I included sexual side effects because we are not living in denial that our adolescents are sexually active. We owe it to them to be mindful of what is going on and empower them with information so they can do this safely. A more potentially serious side effect of SSRIs is serotonin symptom. I will be frank with you. In the 10 years, 8 years that I've been in psychiatry, I've never seen serotonin syndrome. It's an idiosyncratic drug response, and it is very, very rare within the literature. It can have agitation, confusion, and hyperthermia. If it is that you are seeing this, we're transferring the patient to hospital because not even the psychiatrists are managing this. This is a medical situation. This is going to be managed by medical specialists, and it can be safely managed. It just needs to be done carefully in a hospital setting. For our anxiety disorders, we're looking at generalized anxiety disorder, social anxiety disorder, agoraphobia, separation anxiety, specific phobias. The list goes on. And again, history and examination is still the same. But what does differ is the screening tools that you can use. One of my personal favorites is a SCARED assessment tool. And why I like it is because the SCARED can be used for children up to the age of 18. But it also includes a component for the parents. It's a 2-page questionnaire and you tick. And why I find it useful is that the higher the patient scores, the more sensitive and specific it becomes. And why it's useful is that it can help you to identify if this is a generalized anxiety disorder, if this is a social anxiety disorder, if this is a separation anxiety disorder, if this is a specific phobia, or if it's multiple conditions happening simultaneously to help you guide your treatment planning. If you don't want to do the SCARED, that's fine. You can still use the GAD-7, the Generalized Anxiety Disorder 7, the Beck's Anxiety Inventory, or the Hamilton Anxiety Rating Scale. And as again, with depression, history, examination, investigations, and you're looking at the same course of medications, antidepressant, anti-anxiety medication, psychotherapy, or a combination of both. And I've included this because this is what the scared looks like. So it's a 2-page questionnaire. This is the child version. And as you see, 3 questions, and you just tick as you go down. The parent version has the same thing, and they tick as they go down. And then you tally up the scores, and then this is what it comes out as. Each question flags for a different condition. And the higher they score, the more sensitive it becomes. It's not projecting well, but what you will see is that it can also give you a breakdown for which questions are for which specific disorder. So certain questions will flag for panic disorder. Some questions will flag for anxiety disorder. Some questions will flag for separation anxiety disorder, and it goes on. So it can be very, very useful. Next, we're talking about ADHD. Overview of ADHD. It's a neurodevelopmental impulse control disorder, and it's broadly divided into 2 categories, and you're looking for symptoms by the age of 6. First set of symptoms is your hyperactive or your impulsive symptoms. Having a lot of energy and struggling to sit still. Fidgeting all the time, often running around and climbing on things, constantly talking or interrupting others, being very impatient. You have the inattentive symptoms, being easily distracted, making careless mistakes, having a hard time following instructions, forgetting or losing things, having trouble staying organized, appearing not to listen when someone is speaking to them, avoiding things that involve a lot of thinking or effort, and seeming unaware of what is going on around them. Now, I pause here because I do not want us to over-pathologize. There is some level of hyperactivity / impulsivity / inattentiveness that I consider, and within the literature, is considered to be normal. And we have to remember that these are within the confines of our society and our culture. Picnic for run up and down sometime. That is how we view children, and that is reasonable. We do not want to pathologize what is normal. What we want to do is make sure that we are not missing things that are going to affect their functioning at home, with their peers, or at school. So if it is that your teachers are noticing that these symptoms or these behaviors are causing them to affect or to respond poorly in class, we have to step in. These symptoms, especially in boys, can be misdiagnosed or misseen as just behavioral problems, where they're just rock bad picnic. And we try to discipline them, not recognizing that this is an impulse control disorder that needs intervention and needs to be identified. And it has ramifications. There's a seminar work that was done by Prof. Hicklin and Dr. Walcott on cultural resilience and cultural therapy. And they took some of the worst behaving children in inner city schools, put them in a class and used psychotherapeutic interventions, no medications, and were able to get these children to function at a level that was on par with the children who did not have these behavioral issues, and in some instances surpass them without the use of medication. It sometimes has to do with how we are engaging and interacting with our children and our adolescents, right? Now, as I've said, we need to question the level of engagement and interaction at school and at home. We need to address different learning styles. We need to break ourselves out of the idea that children and adults included learn the same way. We know by now that not everybody sits down and can learn in a lecture like this or in a format where a presentation is delivered or listening to someone talk or read from a slide. Some people learn by doing, some people learn by mnemonics, some people learn by seeing, some people learn musically. We have to be able to cater to the different learning styles. And just because a child did that in primary school or prep school doesn't mean that when they get to high school, their way of learning changes. We try to structure and regiment rather than adapting to our patients and adapting to our children. Now, if it is that we think that there may be a behavioral issue or a conduct issue or an impulse control issue, there is still an assessment. It involves the child, it involves the parent, and it also involves the school. The three domains that are most critical. And one of the assessment uses the Connors assessment, and it's 3 sets of questionnaires, one that the child fills out, one that the parent fills out, and one that goes to the school for the teacher who spends the most time with the student to fill out. And it rates the different symptom domains and gives us a better idea of if it is that we're dealing with a conduct issue or a behavioral issue or a neurodevelopmental issue or an impulse control issue. Now, this is a lot to take in. This is a specialty unto itself. Child and adolescent psychiatry is complicated. I am not a child and adolescent psychiatrist. I shy away from children. Cases like this are best served by a specialist. That's why we have our child guidance clinic. Where we fall into the mix, recognizing symptoms, listening to our parents and our patients and the reports that we are getting and the concerns that they're having and saying, you know, maybe this is not just a behavior issue. Maybe this is something more. Maybe we should talk about getting an assessment done and seeing what is the next step. That is perfectly reasonable. We do not have to initiate treatment in our regular offices because there are risks to treatment. One of the 2 medications that is, well, the only medication that is readily available that is solely indicated for treatment of ADHD in Jamaica is Concerta. We used to have Ritalin on the market, not so easy to get. We have off-label use of Wellbutrin, not so effective in some patients. The medication is methylphenidate. It is a psychostimulant. There is a risk to this medication. It can precipitate seizures. It can precipitate psychosis. There is a risk that needs to be weighed against the benefits because medication therapy is not the only form of therapy that is available. Some persons with ADHD can be managed with psychotherapeutic interventions. So when in doubt, you can always happily refer. Eating disorders, anorexia, bulimia, binge eating disorder, avoidant restrictive food intake disorder. This is usually picked up by our pediatricians or general practitioners or our family doctors with a fall in BMI or a fall off in our growth charts. It requires careful history and assessment. And again, because I like to give it out, there is a SCOFF tool which can be used for suspected cases. And I highlighted this study that was done in 2023. The overall proportion of children and adolescents with disordered eating was 22.36%. And girls were more significantly likely to report eating disorders than boys. But you look at those numbers, 27,000 versus 26,000. Let's not miss our boys. The management is intensive. It requires the multidisciplinary approach. You need a psychiatrist, a psychologist, a social worker, an internist or a pediatrician, and a dietitian. There's a role for medications, including antidepressants, plus or minus antipsychotics, and the additional need for supplementation, as well as continued follow-up with both the family doctor and the family for support and tracking to make sure that we're not missing anything. And this is a SCOFF questionnaire, and I love it because it's easy and it's fast. 5 questions. Do you make yourself sick because you are feeling uncomfortably full? Do you worry that you have lost control over how much you're eating? Have you recently lost 1 stone, which is 14 pounds, in a 3-month period? Do you believe yourself to be fat when others say you're too thin? Would you say that food dominates your life? Each yes equals a point, and a score of 2 indicates a likely diagnosis of anorexia nervosa or bulimia nervosa. Very easy. Substance use disorders. We are leaving for Miss Curley. I will not steal any of her thunder. And finally, self-harm and suicide. There's an increased occurrence across the world, and it's an area of special clinical focus among psychiatrists, non-suicidal self-interest behavior. This is every parent's worst nightmare. This is every doctor's worst nightmare because we panic, we get afraid, rightly so. We want to protect our children and our adolescents. The problem is that it's associated with multiple conditions: depression, anxiety, trauma and PTSD, neurodevelopmental conditions, frank psychosis, and in some cases, psychological issues. It can have a pure basis in poor coping skills and poor interpersonal connections and poor conflict resolution. And because of that internal anxiety that builds up, that an adolescent developing brain is unable to conceptualize or process, they externalize this anxiety by self-harming, because physical pain, one, relieves endorphins, so you feel a little bit better, and two, it distracts from the internal pain that we're feeling and helps to reduce that internal anxiety. So it involves us talking, gentle parenting, and actually screening for the causes of these conditions. Home-related, there's an exposure to trauma, in-home pressure from parents, inability to process complicated emotion, and low emotional intelligence in the home. School, inability to keep up in class, unrealistic expectations from parents and teachers, bullying for whatever reason. That's the bad. How do we prevent it? Because it's always better to prevent than to cure. Forums like this, we educate. We have mental health education programs for our physicians, for our family physicians, for our general practitioners. We have these programs within schools. We have these programs within our churches. We have these programs wherever children and adolescents congregate in a way that is engaging for them. Difficult, but doable. There was a recent announcement of a chatbot that was created by National Family Planning Board, I believe it was, that is giving age-appropriate information for children. Beautiful use of AI, in my opinion. Children may want to get their information online, that's fine, but we have to ensure that we're at least putting them in the direction of good sources of information. We need to learn to build resilience in adolescence and to not be hypercritical. We need to create supportive environments. So when people make mistakes, we need to be able to constructively criticize, not just berate and bemoan and belittle and bemoan what has happened. We need to be able to reassure. We need to be able to encourage and to empower, to learn, to build this internal capacity to face future challenges, because it has a very clear trajectory. If in one case you do not learn, if you are facing a crisis and you go in two different directions, one case where you build capacity and you do not build capacity. In the case where you build the capacity and the resilience, when you face another crisis, you can step up to meet the challenge and you're better able to emotionally regulate what is going on. So you can face that challenge down and it carries forward. But when you have not built that capacity for whatever reason, every single challenge that comes ahead of you becomes a daunting task and you don't know how you're going to face it. And as a result, you crumble. So we need to create supportive environments. So let's wrap up because I've been speaking for far too long on this Sunday morning. There's an increased clinical significance of multiple child and adolescent mental health conditions. There's an increased need for screening with pediatricians and family doctors. The role to begin relevant investigations and institute management is critical. We need to be able to spot these conditions and be able to either initiate treatment or refer them for further management. It has implications for long-term physical and mental health and the ability to function at home, at school, and among family and friends. And if in doubt, shout it out. Feel free to refer. Thank you for your attention.
We thank you, Dr. Eaton. It is, as I said originally, that you are comprehensive and empathetic. We would like to just say that, wow, it certainly seems that our world is being traumatized. When you tell us that 16 million adolescents live with a mental disorder, live with depression, 4.5% here in Jamaica. Our environment certainly isn't helping us. We read and we see daily what's happening with our families, with the trauma, the school, the fighting, the violence in our communities. They, they are all significantly dysfunctional at this time. And this new world of regimentation also is not helping. So we're having this prefrontal cortex, which is malfunctioning, it seems, not only in childhood, but I guess they grow up throughout life, seeming to span all the decades.
And it carries forward.
But you have said family support, increased mental health access, more coping mechanisms to be shared with us, and quick early identifying the problem. So I just want to thank you. We'll have a Q&A later on. And I'd like to apologize for presenting your older biodata and ask you please to take 30 seconds, please, and just add in, because you have nearly 220 people who are here, 220 physicians, and so you want them to know, and we want them to know what you have. So please update whatever I
Okay,
left
sure.
out.
What's changed on the bio? I finished residency, so I'm now post DM. So I'm a senior registrar with the St. Catherine Health Department. I no longer have work with Pure Jamaica, so I do my own practice virtually and in person, depending on. Contact information is available 571-9790 or jordaneaton876@gmail.com. And the only other thing to add is I've done a few publications on the use of psychedelics in Jamaican context, and my research project got some awards at the National Health Research Conference the other day. That's about it.
Ooh, congratulations. And yes,
Thank
we
you.
did mention that you are that you're qualified. So fully qualified and
Fully qual.
working with St. Catherine. Yes. And thank you again. Thank you.
No
We
problems.
always appreciate you. Notice that we favor you. We appreciate you at all times and your clarity. And at this time, I'm going to move on to our next presenter, who is Dr. Judith Leiber. Now, Dr. Leiber is a physician who is well known to me for almost half a century. She is one of my sister's very, very dear friends. They met at Immaculate Conception High School, and they are still very, very close. It is always my pleasure to see and talk with Dr. Leiber, who is an accomplished and experienced medical professional specializing in both pediatrics and psychiatry, with an MBBS and DM in, in psychiatry and pediatrics, as well as having completed a clinical fellowship in child and youth psychiatry at the University of the West Indies. She is uniquely and comprehensively skilled in addressing the mental health needs of children, adolescents, and adults. Dr. Leiber currently serves as the Director of Child and Adolescent Mental Health at the Ministry of Health and Wellness, and brings to us over 2 decades of invaluable expertise garnered from her work in various child guidance clinics across Jamaica. She's respected as a pediatrician and consultant child, adolescent, and adult psychiatrist, and has been at the forefront of providing exceptional mental health care to diverse populations. In her role as an associate lecturer at the University of the West Indies, she continues to contribute to the academic and professional growth of our future doctors. And her leadership has been instrumental in developing essential protocols for us, like the guidelines for diagnosis and management of common mental disorders in children and adolescents. She has played a pivotal role as a point person from the Ministry of Health and Wellness in the successful implementation of the school mental health literacy curriculum. It's used in high schools and it fosters better mental health awareness and support for our educational institutions. Dr. Leiber has an unwavering commitment to enhance the mental health services that exist in Jamaica, and she advocates for mental health literacy. And this just underscores her indispensable contribution to the field of psychiatry, especially child and adolescent psychiatry. It is my great pleasure to welcome Dr. Judith Leiber to address us on the topic of digital health, the impact of social media on adolescent health and mental well-being. Welcome, Dr. Leiber. Over to you.
Thank you, Dr. Brown Morgan. Thanks for that introduction. And thanks to the organization for inviting me. So I'll just go straight now into sharing my screen. Okay, so the topic is the impact. Oh no, I'm sorry, it's not on slideshow. Oh, supposed to be. Okay, the impact of social media on adolescent health and well-being. So I'm going to start off with a story and then we explore what I call the good, the bad, and the ugly of social media. And then we'll end with some tips or some discussion about the way forward. So let me. I have a pediatric colleague, and about 10 years ago, she said to me, Judith, are our children becoming more fragile than before? They don't seem to get more depressed than, than we did in our time. So I kind of dismissed the question and I tried to rationalize the fragility of our children by saying there's probably more awareness about mental health, there's less stigma, so more people are talking about it. The social fabric is somewhat disintegrating. We have more trauma, more adverse childhood experiences, and a combination of this could lead to what we see as fragility. And if I follow on Dr. Eaton's excellent presentation, I guess a lack of resilience. And we also noted suicidal talk for trivial reasons. Your mommy won't let you go to the party or school, and you're threatening to kill yourself. So quite, what shall I say, coincidentally, providentially, I was doing some research on social media. And I found that this doctor, Dr. Jean Twenge, she's a research psychologist, and that from 2017, she actually sounded the alarm bells that she thought social media was adversely affecting our teenagers, and especially their mental health. I'm going to tell you why she said this, but basically when she said that, she was accused of being sensationalist, alarmist, and she was also accused of not having sufficient data to substantiate her claim. This is how she looks. We had wanted to invite her for our psychiatric conference, but we could not afford her fee, as you can imagine. So I'll try to present some of her, her findings as best as I can. So what happens is that every year they ask teens in the US, they have large national surveys where they ask teens about how they're feeling. And she was studying generational differences for about 25 years. And then she started to notice sudden changes after 2010. So I'm sorry that the numbers aren't too clear at the on the x-axis, but I hope you'll trust me that when the graph takes off, it's at 2012. So in 2012, she's found that the graphs were taking off for children feeling left out, feeling lonely, those diagnosed with major depression and severe impairment, those who were complaining, I can't do anything right, my life is not useful, I do not enjoy life. And the suicide rate had also increased. This is one with a suicide rate for both boys and girls. Now, she said to herself, what could be causing this, this like kind of exponential rise? And she said, perhaps economic conditions. So she got a mapping of the rate of unemployment over the years. And what she found was that actually, in these kind of troubled years for the kids, unemployment was actually less. So that means that it couldn't be ascribed to economic problems only, or even at all. So she had to look around for something else. And therefore she concluded, she said, well, what has come into our life, or especially teen life, since 2010, 2012 and onwards? And she concluded that more and more of us and more of our teens had obtained smartphones. So she started off with some, simple advice. Only use your smartphone for an hour or two and then go and live your life. Your phone should be a tool that you use and not a tool that uses you. Okay, so 2017, she says this, she shut up. What happened subsequently is that some whistleblowers who used to work for the tech companies emerged, and they gave us a lot of information. They told us that the tech companies get attention engineers, the same folk who devised the slot machines in Vegas, to develop these apps. So therefore it had the same kind of almost addictive quality, that they were all trained, most of these engineers were trained in persuasive psychology. And of course, I told you about the slot machine analogy, where you keep going back and going back and going back, only partial reinforcement. They also underscore the fact that these tech companies, Facebook, etc., it's a business. And basically what they're selling is your attention and your data, and they are using you. We all know that sometimes we go down the social media rabbit hole. You say you're going to look at one thing and something pops up and you go into something else and and then 1 hour later, what have I done? Okay. What was particularly distressing was that Facebook had data, psychological data on the effects on teenage girls, the deleterious effects on teenage girls for some time, and did not reveal it to the public. And even now, up to today, they have not revealed it to the public. They also spoke of a special type of Instagram, which was scrapped because people were saying, no, that's not, that's not on. And in fact, one of the main guys who was a whistleblower and who was actually started a center, we'll get to him later, he advocated that app creators, particularly for young children and going all the way up, should have a Hippocratic oath that they abide by, because basically all they were thinking of was getting this child hooked on the game. They weren't thinking of any other effects on our children. So in summary, the whistleblowers told us that all of these companies were looking at profits over safety of our children and ourselves. So let's look at the good, the bad, and the ugly. Now, nobody not me, is saying that social media does not have any good qualities. I mean, we had to use it in COVID. It was a good way of keeping in touch. However, we have to admit that there's the bad and then there's the ugly, and we're going to just explore that a bit. Now, just around the time when I was researching this, and we were having our conference, that is JPA, the Surgeon General issued his directive. And basically he was saying that social media is harmful, that they are some of the most, for too long, we have placed the entire burden of managing social media on the shoulders of parents and children, despite the fact that these platforms are designed by the most talented engineers and designers to maximize the amount of time that our kids spend on them. It's not a fair fight. But we have the big tech companies and then poor us as parents and children and, adolescent advocates. It's not a fair fight. So the Surgeon General is saying government or organizations, big organizations need to get involved. And then in 2022, this guy who is the head of the American Psychological Society actually testified, and he explored some of these issues. Now, I'll just, as I said, there are positive attributes. So particularly those communities who may be kind of marginalized, social media affords them the opportunity to link up with other people of similar maybe identity or similar leaning or, some other attribute. And so they find a place in a community. We know that it has great potential for immediate social support, and that used properly, it can buffer the effects of stress on suicidal behavior. Unfortunately, we've had some anecdotes of, the opposite, but I won't go into that now. And of course, this is reiterating again the social companionship during the COVID-19 lockdown. So I'm going to mention some of the bad. So particularly for teenage girls, first of all, social media seems to have more effect on teenage girls, whether positive or negative. So for some reason, our girls seem to be more susceptible or vulnerable to the effects of social media. We're not quite sure why. So some of the bad effects that our teenage girls encounter is the online social comparison, feedback seeking. I mean, if you don't answer my post in X amount of time, and if I don't get X amount of likes, I'm down in the doldrums. And then this kind of social comparison led to depressive symptoms, anxiety symptoms, weight-related disorder. And Dr. Eaton mentioned, the eating disorders. And of course, online, sometimes the teens are told about crazy diets and crazy workouts because they have to, get a certain shape and a certain weight. Okay. It's also felt that social media has a contribution to heavy episodic drinking. And that, of course, would be a bad effect. The flip side now is, what are the teens not doing? So if they're on social media, what are they not doing? So you have positive, when I say positive effects, you have actual effects that social media brings with it, but you also have effects that because you're on social media, you're not doing the healthy things which you should be doing. And it was certainly found that a lot of students, this is US, we're getting less than the optimal amount of sleep. And we all know in mental health, if you don't get enough sleep, it affects your mood. We know it can affect your concentration and ability to pay attention. It can affect your health, ultimately. So sleep is very important, although our teens probably think that, well, they don't need a lot of it, but it is important. Now, this was very interesting to me. So Dr. Arna spoke about the prefrontal cortex, and the prefrontal cortex is where your conscience resides. So if you have, been properly taught manners and taught right and wrong, gone to Sunday school or whatever religion you ascribe to, where you have a moral code, when you see something that that is wrong, you consider wrong, the prefrontal cortex gives a certain signal, right? So it gets activated. And when you see something that is neither here nor there, of course, it does not get activated. So we're going to call that the green light. Now, what happened in this experiment was that this fellow was given this video to view. Now, obviously, this poor guy is being bullied by this guy, actively bullied by this guy, and all the others are taking pictures of this incident rather than helping him. Now, when it was first presented to him, the number of likes was not presented to him. And therefore, the electrodes or whatever that were monitoring his prefrontal lobe went off, because like any normal human being, he would realize that this is not right. This is not right. Bullying is not right. However, what they found was that when the number of likes was presented to him, which is almost 2 million likes, the prefrontal cortex was completely deactivated. So it was almost like paralyzing the conscience. And, I find that very, very alarming. Okay. Another bad as well is that, we want well, especially in the States, they want psychologists to be able to do more research on what social media has done. But what has happened is that the tech companies are now luring the psychologists to work for them. So there's a little kind of tussle right there. All right. Now, what can we do in Jamaica? Okay. All of the literature speaks about parents talking with children. And, I thought back to our Jamaican scenario, and I realized that a lot of our parents really do not or cannot speak with their children or their teens. So we have a major hurdle in terms of getting the message across to our children. We would like our children to know the things that I showed you on the about the whistleblowers, that this thing is really a business, that their attention and data is what is the currency, and that they're being intentionally hooked. So how do we transmit this to our teenagers? We really would like our parents to transmit it to them. But as I say, I think we have a big hurdle in terms of our parents, most parents sitting down with their teenager and having this kind of discussion. Of course, we would have to educate our parents first, right? I can tell you that taking away the phone is totally out. It's totally out. One, because again, the good and the bad. Our society now demands that a lot of our teens, and even, well, a lot of our teens communicate, let's say, about work or other things via their cell phone. So taken away from them, it would just be it's not recommended. So there is an adage, tools versus rules. So we need to give them tools in terms of social media and their use of social media versus rules. No, you can't have this, you can't do that, You can have some rules, like not having your phone in the bedroom at night, no phone at the dinner table. But what the young people are saying is that we adults set these rules and we don't adhere to them ourselves. So that is something that we have to be very mindful of. Okay. So this is just to reiterate again, you have to start talking about appropriate technology use, often build trust, and where there's a problem, whether it's been bullied or seen a disturbing image, your child will talk to you about it. Now, let me say something about bullying. Dr. Eaton mentioned it. The thing about bullying is that if it's even actual bullying, children are very, very, very reluctant to tell their parents and even their teachers because they feel that something is wrong with them. They're weak. That's why they're being bullied, and they feel ashamed. They feel ashamed and they don't seek help. And of course, you can imagine when you get into the cyber world with cyberbullying, where you probably did something that you were told not to do, or you were warned not to do, and you did it, you're going to be even more reluctant to seek help. So this is an era where I guess a trusting relationship and some amount of some amount of building rapport that you can so this young person feels comfortable enough to share this with you will be needed. The next bullet speaks about parents assessing their child's activities on social networking sites. And well, the flip side to this is that a lot of teenagers seem to have fake Instagram accounts or fake whatever accounts. So they have one account that they show to mommy, and mommy probably has the password to that, but then there's another account that they do their own thing, right? So it calls for us as parents to be more educated about the online space, okay? Then now that communication again, you need to talk to your kids, or rather listen to them. And this is an adage that we have said in child guidance many, many times. The ratio of a parent listen to a parent talk should be at least 5-1. Now, I'll give you an example. In the clinic, I remember I had this young man and his father, and I was asking them how they're related. And Daddy said, Miss, we drive from Portmore every morning and we talk for the whole hour. And when I said, we talk for the whole hour, and then the young man kind of made up his face, and I said, who is doing the talking? And basically what was happening was that Daddy was talking and lecturing and whatever and preaching, and the boy kind of zoned out. So this is something that are very hard for our parents to learn, but they should at least listen for 5 minutes for every 1 minute that they talk. Very, very difficult. What are other recommendations? Something called mindful social media, where you make make a concerted effort to say how long you are going to go on social media, what you are going to research, what exactly you're going to do, so you don't get caught down the rabbit hole, okay? The second bullet would be critical thinking, shortening the amount of time between questioning the veracity and the authenticity of what you see. So you see a lovely picture of somebody who you may only know casually, and she's at a lovely resort and she looks beautiful and she has a lovely boyfriend beside her. So you say to yourself, wow, is that authentic? That's probably her best bathing suit, and this is a 1 in a million time for her maybe. So you don't get into the comparison, what they call comparison anxiety. Following on that, we have to try to decrease upward comparison. Try to get them off social media, all the time, and speak about what filters were probably used and how these posts were curated or highlighted to really make you feel jealous, to make you be in awe of what you're seeing. Okay. Now I'm going to tell you something about teenagers. My son, when he was a teenager, I think it was something about food. So I said to him, why don't you eat your food? Don't you know that there are people in, let's say, Ethiopia or whatever, starving? And then he turns to me and he says, Mommy, why are you comparing me downwards? Why don't you compare me with the child who is having champagne and caviar for breakfast, right? So you have to be aware of how our teenagers think and be able to have a good retort, rebuttal of what they may say to you, because I mean, they have their thinking, they have their ways. Okay. Um, for let's say you have a teen who posts a nice picture, yes, but then you can also try to encourage empathy. So when you put this picture online, what do you really think that your friends are feeling? Is it envy? Are they feeling like they're lesser than? And try to try to stimulate that amount of empathy. Again, asking, is that real? And of course, the fake accounts. Okay, so one way, in Jamaica to figure out what may be going on is using the National Child Development Agency surveys. They do a global school youth survey ever so often. See if our international development partners will fund a specific survey. And then we could also have, youth focus groups to tell us some more. Now, I want to give you some resources that will help you. And even, I guess, again, our parents can go on it. So there was a recent webinar, as recent as last week, on how to keep teens from feeling sad on social media. How to keep teens from feeling sad on social media. No, I don't think anybody has really explained why do teens feel sad, apart from the comparison anxiety, but also it is thought, and it's not thought. I mean, we know that we as human beings need face-to-face interaction. And therefore, the more online that we are, the less something inside of us is not being fulfilled, and therefore more of a greater tendency to become depressed and anxious, right? So as I said, this webinar was last week. It's on the Child Mind Institute website, and it advocates tools over rules. And it suggests certain things that we could ask our children or get our research ourselves, apps to track our online time so that we're more mindful of it and we're not taking down the rabbit hole. We ask people to detox. So you have a teenager who may be having some symptoms of depression and anxiety, and they're pretty aware, and they will be they will be willing to work with you. Some doctors, psychiatrists, have recommended that, okay, come off of this app for a week, or come off of your phone for a week. Just do a week, and then you'll come back to me and you tell me how you feel. And invariably, the doctor says that the young person realizes that their mood increases. And even better, if you can get the young person with a group, so a group of friends come together and we say, okay, we're going to come off Instagram for this week. And, they kind of hold themselves accountable, and it becomes a group effort. It will be much more effective. I don't have it here, but I think most of you have heard of FOMO, the fear of missing out, which is what young people feel a lot when they're not on social media often enough. And it's recommended that we can reframe it. I don't know how many of you heard Dr. Wright's talk last week about reframing. So the Childmind Institute recommends that you try to reframe it to say, what's the joy of missing out? What can you do with that time that you would normally spend on social media? We know our kids are not getting enough exercise. As I said, they're not getting enough sleep. Their attention is being distracted. I mean, when you read the data about how many times they check this app or that app, it's alarming. So we need to ask ourselves, and we need to get our kids to answer the question, what are you missing out on when you go on social media so often and for so long? Now, one of the questions that came up was, when should I buy my teen his or her smartphone? And I'll just tell you that we had some teens at the Jamaica Psychiatric Association who were kind of giving their account of their feelings about the smartphone. We asked them this question. Most of them said something like 13 years or age 15, which it sounded good, but I'm not sure if that's practical. I don't have an answer for you. As I say, you can go on this website and see the pros and the cons. But what happened is that those teens, they really had a kind of protective attitude towards their younger peers. And they wanted our younger siblings, they wanted them to be kind of protected from this entity for as long as possible. So I know that that's probably one of the questions that you may get asked from your parents. And then these are some resources. The first one, the Center for Humane Technology, resources for controlling tech use. This is I don't remember his name. This is the guy who suggested that we should have a Hippocratic oath for persons who create apps. Behind the screens, what teens are facing and adults are missing. And then Center for Digital Thriving Resources and there are other webinars. I'll just conclude by saying, I mean, I spoke about the good and what the good, the bad, and the ugly. The ugly to me is what the tech companies are doing to us unknowingly. And we were ignorant up until now, but as I said, the genie is out of the bottle now. The bad is the deleterious effects like the depression, the comparison, anxiety, etc. And then the good, it was found that if they didn't want, okay, so the experts did not wish to put a time restriction. I know all of us like to say, how much time should they spend on the screen? And we give various hours. And I think it is useful, but they felt that we should have a deeper conversation with our teens in terms of what are they doing. So the more active they are, and if they are searching for topics that are in line with, their interests and let's say their moral codes and so forth, that of course would be more a positive effect as opposed to just passively scrolling through and just kind of almost imbibing everything that you see on social media. So apart from the time, there was also an emphasis on what are you doing on social media? Is it active or passive? And assessing that in terms of the positive or negative effect. So with that, my dear people, I will now sign off. And I guess later we'll have questions. Thank you.
Thank you, Dr. Leiber. You have just alerted us to the use of social media apps and their addictive nature, and also the deceptive nature of what's happening. And we need to actually know, because many of us personally are also addicted as adults. And we now need to exert a greater influence and a greater discipline over ourselves, as well as setting that example for our children and bringing, in fact, it seems as if this is something that when you give your child a phone, you need to have that conversation. Just like when a little girl has her first menstruation, it needs to become a part of what we do. And, you know, we are caught up ourselves in this social media. We do need to be more caring and careful, especially when we see what's happening with our teen girls. And yet I wasn't surprised to hear it, even because I have experienced it with some of my patients. So I want to thank you so much. I hope our psychologists in Jamaica are not not going to these companies, and they're staying with us on the right side of the balance. Parents need to talk with their teens, and they need to listen to their teens. Talk versus listening, 1 to 4, 1 to 5, 1 to 5. We need to let our children talk. We need to hear so that we can then give appropriate guidance instead of just talking at them without knowledge. So I'd like to thank you so much, Dr. Leiber. You're going to have Q&A later, and I'd like at this time to just push one thing for Dr. Leiber. She is asking each and every one of us as physicians here on this meeting today, please to lobby with the NHF to include Concerta. I think we heard that too from Dr. Wright last week, to include Concerta as one of the NHF subsidized medications, because it is so needed and it is so expensive. So please, everybody here today, please, when you go to your office during this week, send a little note to the NHF by email or give them a call. Let them know that we need Concerta, because we need to celebrate and to properly help our children in their needs and to help them with their development. Now,
If I may,
thank you again, Doctor.
If I may, Dr.
Leiber.
Arna. So
Go ahead.
You explained it well, and I thank you. More precisely, you can say you want Concerta to be on the individual benefits listing, which means that our parents can go to any private pharmacy in Jamaica and they will get the subsidy. At this time, what they're saying to us is, oh, it's available at cost price at the pharmacy, DrugServe pharmacy. That is not good enough. That is not good enough. All right. So thank you.
Individual benefits
listing. Yeah, we want it on the individual benefits listing. Thank you.
Thank you, Dr. Leiber. And we have here now, we'd like to invite our Abbott nutritional sponsor to share their products with us before we move on to our next speaker. Over to you, Sam.
Thank you, Dr. Brown Morgan. I think Abbott is not here with us. Please move on to the next presenter.
Oh, okay. Hopefully, as they are a presenter, we want to represent them, because they're helping us today. So if you get something from them, please let me know, and we will present their products. And we want to thank them today for being one of our sponsors of this meeting. Moving on, I have the pleasure of introducing Miss Colette Curlew, who is with us today, and she is a experienced psychotherapist, life coach, and trainer with a demonstrated history of working in the healthcare industry. Ms. Curlew is currently the director of the Client Services Department at the National Council on Drug Abuse and has over 15 years of experience as a licensed psychotherapist. She specializes in substance use disorders, prevention, and treatment, and has devoted herself as a public servant to the advancement of Jamaica, accomplishing its Vision 2030 goals. Miss Curlew is a family person, and she loves exploring the whole world, or the world around her too, in detail. But there is nothing she says she loves more than empowering people to live fulfilling and joyous lives. Now, Miss Curlew is going to speak with us on substance abuse and addiction, identification, intervention, and referral. Please let me ask you now to welcome Miss Curlew. Please speak with us now. Your turn.
Thank you so much, Dr. Morgan. Good morning, everyone. Is morning still? Yes, it is. And I will try and be as succinct as possible. So, Dr. Leib, I really liked your presentation that spoke of the fact that parents need to be a little bit more involved at trying to put it on full screen. So let me just do it first before sharing. Yes, parents are a critical part of what we do. Hold on again. It's not allowing me to do it. Just give me a moment. I'm trying to make sure that I can show you everything in full screen mode, but it's hiding it down the bottom. Share. Okay. I'll move this down shortly. Awesome. All right.
Perfect.
You're seeing the bar across though, right?
No, we're just seeing National Council on Drug Abuse.
Okay. All right. Let me go
So
back
you
a
can
bit.
move that bar if it's blocking you.
Yeah, but let me go back a bit. Okay, back. All right. So, as I say, thanks again for having me, the Caribbean College of Family Physician and the Jamaica chapter specifically. And today we'll be talking briefly about what we do at NCDA, what's happening in Jamaica, how we can identify substance use disorders and signs of use, how we screen, what are some of the programs that we have, and how we refer. And just to let you know that what we're trying to do is to use more friendly language, so misuse versus abuse and addiction with more substance use disorders. So we're not calling persons addicts anymore. We're being very careful in our language and empowering them so that they too don't feel judged or any stigma. So what do we do at NCDA? We do research, and Dr. Leiber would have mentioned it. And so we can present that to help guide policymakers and develop evidence-based programs, and also use it to plan our programming and to collaborate with other MDAs and other faith-based organizations, CBOs and NGOs. And we also partner with international agencies so we can fulfill the mandate of demand reduction. And it was established in 1983, so we're actually celebrating 40 years this year for drug demand reduction. What we have been seeing at NCDA, and I must tell you that pre-COVID, for the period April 2022 to 2023, we had 1,288 clients in treatment. And pre-COVID, you would have seen 70-something% of those being children, but this is now 57% and it's climbing. So normally those that are referred to us are children under 18 And those are who we see mainly. We have drug prevention programs in school, impacting about 2,500 children. We're in about 80 institutions across the island. We're doing rapid assessment as we see the need to, so that we can be more aware of what's happening in the field. And because it's so expensive to do a general survey, the rapid assessments help us to keep our ear to the ground. And we're seeing a lot of referrals coming in, and because of the increasing use of MDAs, edibles, and vaping amongst our children, despite that substance use of tobacco and cannabis and alcohol still continues among them. And just to give you an idea, when we did the last, you would have heard Dr. Leiber mention these store surveys. And I think the last one was about 2017. We're doing some more next year. We would have seen among the adolescents, right? So this is Global School Health Survey, Global Youth Tobacco Survey, and National Secondary School Survey. We'd have seen alcohol use of 40%, current use. And current use mean within the last 30 days did you use. 40% for alcohol, 13% for ganja, 12% for tobacco. And the average age of onset will be about 12 to 13, with 80% of them reporting use before age 14. 50% of them say it's easy to get it. They go to the shop, the neighbors, the communities in their home. There's heavy exposure, as we say, in the home. And that influences them, as well as the environment, the community. There's low enforcement of laws prohibiting sale to minors. The highest for tobacco is for tobacco, and it's the changing level of ganja is happening. And we assume it's because of the decriminalization, because the year before that, or the period before that, it was lower. And knowledge, what we know is that even though they know it may not be good to them, they're still using it. There's significantly higher use among males, even though the gender gap is narrowing, and the highest use is in grade 10. Anybody wants to guess why grade 10 would be why they're using it the highest? Anyone? Why would grade 10 be significant to them to be using? 7, 8, 9, 10. So that's fourth form. Anyone?
Miss Curlew, please let us hear, because none of us know. Go ahead.
Well, some assumption will be those are the teenage years that they're experimenting, but also that's when pressure is on at school and they're trying to fit in more exams coming up. This is when you get to the CSEC time. So those are critical time. And I guess the relationship at home, the parenting factor is significant for them. And it may not be going so great at that age, because at that age, I don't know if they're like me, but I knew more than my parents at that age. So we did a rapid assessment situation, which is more qualitative. And we did this in May 2022, after we heard about the vaping happening and the surge in Molly use amongst this population, to see what's happening amongst the children. And this is what we found out, that the mental health was high amongst them, especially anxiety, depression, and they had suicidal ideation. There was verbal and physical aggression happening, weapon carrying, excessive sexualized behavior, and pregnancy happening. The drug use was also increased, and there was also increased access and exposure. Scamming or chopping the line was happening more, and also occult practices. And we would have heard the many songs that came out and what's happening on the social media. Dr. Leiber would have mentioned some of that. And see there again, lack of parental guidance and their participation in it too. And then coping with grief, loss, abuse. You'd have heard what came up more at that time too was the sexual abuse was happening more at home, the chaos that was happening. And this is on the heels of the COVID-19 as well. I hope the dog not impacting you too much. Let me know if it is. So the substances that they're using more now, or that's more popular amongst the adolescents, are Molly, vaping, or vaping stuff, and edibles. And in this context, the edibles referring to ganja-infused edibles. Where are they using? So these are some reasons that were given for their use. The influence, the family, friends, community, popular culture. Those are some reasons why they're using. To cope with life, to manage the difficult circumstances. They were curious. They want to experiment. And it's readily available to them. And it's also the reality of a developmental phase, which is why I'm saying at that age and stage, they're experimenting. Nothing can happen to them. So if you know all of that, the low risk perception and easy access as well. So that didn't help the fact that they want it is available. Why do we use generally though? To feel better, to feel good, to do better, and to explore. So these are just the general reasons why people would use substances. How can we identify when persons are using? So the DSM-5 would call it now substance-related disorders. And there are two categories, substance use disorders and substance-induced disorders. And substance use disorders are patterns of symptoms resulting from the use of a substance that you continue to take despite experiencing problems as a result. And with the induced disorders now is when you have intoxication, withdrawal symptoms, or other substance medication induced mental health disorders. And it is directly related to the substance that's being used. And for the DSM-5, you have 11 criteria that are there, taking the substance in larger amounts for you to diagnose a substance use disorder. And as we're saying, we're not saying substance abuse no more. The term that is being used is substance use disorder. We're not calling anybody an abuser. We're going to call a person with problematic drug use. We're not labeling them as we did in the past. And where the person is taking the substance in a larger amount or for a longer period than you're meant to, you want to cut down or stop using, but you're not managing to do it. You're spending more time getting it or using it or recovering from it. There are cravings and urges to use it, and you're not managing to do what you should do at work, home, school, or because of the substance use. You're not being able to meet what is required of you. You continue to use, even when it causes problems in relationships. Giving up important social, occupational, or recreational activities because of the use, using it again and again, even when it puts you in danger. Continue to use even when you know you have a physical or psychological problem that could have been caused or made worse by it, and needing more of the substance to get the effect you want, and that's called tolerance. Or you may develop withdrawal symptoms, which can be relieved by taking more of the substance. I remember speaking to someone one time, and her father would drink, and she said, boy, I don't know why he does it and he doesn't stop. So I said, well, have you considered that's his new normal and he can't live without it? And that's one of the substances that withdrawal can kill you. So you need to get treatment and medically treated for that one. So the severity of it, mild, moderate, or severe, will depend on how many symptoms you have. So if you have 2 or 3 symptoms, it's mild. 4 or 5 is moderate, and 6 or more, then you have severe. And that's what you would diagnose the client with. And there are 10 categories of drugs: the alcohol, caffeine, hallucinogen, inhalants, opioids, tobacco, cannabis, stimulants, hypnotics, or sedatives. So what is addiction? What you usually find happen is that the brain reward system are essential to the problems arising from drug use. You're doing it to feel good. It makes you feel better. So the rewarding feeling that people experience due to taking the drugs may be so profound that they neglect other normal activities in favor of taking the drug. One of the clients back in the days was, his drug of impact was crack cocaine, and he described it to me, and he said, taking a high from this or a hit from this is like having an orgasm 20 times. You know, that's just how he felt about it. And so it was a good thing for him to do, and it just made him feel good. And neither describe addiction as a chronic relapsing disorder. And that's critical for us to know, it's relapsing. It's going to happen again. It hardly happens where the person quit one time and it's finished. It's chronic, it's relapsing, characterized by compulsive drug seeking and use despite adverse consequences. It's considered a brain disorder as well, because it involves functional changes to brain circuits involving reward, stress, self-control, and those changes may last a long time after a person has stopped taking the drugs. And it's a lot like other diseases. So that's how I'd like you to look at it, please, such as heart disease, diabetes, hypertension. They disrupt the normal healthy functioning of the organ. Both have serious harmful effects, and both are in many cases preventable and treatable. And you'll all agree that that is true. And if left untreated, then it can last a lifetime and lead to death. And then you have substance use disorders, which involve problems that are caused by the effects of substances. And some of these includes substance-induced mental health disorders, intoxication, and those that occur because of withdrawal symptoms. So when we look at what a teenager using substance may look like, what you'll find is that their sleep pattern will change. The relationship is going to certainly deteriorate. You're going to find that their academic performance will go down. They won't pay attention to hygiene. They'll walk past and go, wait, something is happening here. Why am I smelling this or that? Because that's no longer important to them. You'll find that the behavioral pattern will change for no apparent reason. They may become withdrawn or hostile, and that depends on what substance they're taking. There's excessive secrecy. The physical signs, you will see the bloodshot eyes or the lips or the fingers. There's truancy because they're going to be missing out on school because you have to go and seek the substance and go spend the time with the friends. And what they usually enjoy doing, you find they don't like that anymore, and you find that they have changed their friends. So these are some cues that you can pick up on and advise your clients or patients accordingly. How do we screen? We do interviews, self-administered questionnaires as well as biological markers. So you do the breathalyzer, the blood alcohol level testing, the saliva or urine testing, and the serum drug testing. So some examples of screening tools that are very effective are the alcohol, smoking, and substance involvement screening tests. ASSIST is an 8-item tool that can screen adults and adolescents, but usually we use it for generally the older population, and you can test for multiple substances with that. You have the CAGE, which is a simple pre-screening tool, and the CRAFT is what is recommended. And I'll show you what that looks like quickly. So the CRAFT is a short clinical assessment tool designed to screen for substance-related risk and problems in adolescents. And CRAFT stands for the keywords of the 6 items in the second session of that assessment, which speaks about car, relax, alone, forget, friends, trouble. So this is what it looks like. So you would say to them, you let them know, and the patient completes it, but you let them know that they are to answer the questions as honestly as possible. You want to make them feel safe in this space, that is confidential, and you'll have that discussion with them before. So they know when they're answering it. Remember, if they're a threat to themselves or somebody else, that's when you can share information. So you just remind them what you need to share and when you can share the information. But in order to treat them or manage what's happening with them, then they need to be honest with us, with themselves, so that they can get the best care, and it is confidential. So you ask during the past 12 months on whom, well, this is a test that they would do themselves, a screening tool that they would use and fill out. During the past 12 months, on how many days did you drink more than a few sips of wine or any drink containing alcohol? So put a 0 if none, but if not, how many days? And you put the days there. Using marijuana or cannabis, weed, oil, wax, or hash by smoking, vaping, dabbing, or in edibles, or synthetic marijuana, no, because that's something like K2 or spice. And some of the vape pens are laced with those as well. So you put the number of days there. use anything else to get high, like other illegal drugs, the pills, prescription or over-the-counter meds, and things that you sniff, huff, vape, or inject, put as 0 if no days. And if using a vaping device containing nicotine and or flavors or use of tobacco, put as 0 if none. So you put it, and you include e-cigs, mods, pod devices like Juul, disposable vapes like puff bar, vape pens, or e-hookahs, cigarettes, cigars, and all of those are there. So then they'll read these instructions, and if it's somebody that may have a challenge reading, then you ask if I can assist you with it. If you put 0 in all of these boxes below, above, answer question 5 below. So you have a skip pattern. Then stop. If you put 1 or more for question 1, 2, or 3 above, answer questions 5 to 10 below. And if you put 1 or more for question 4 above, answer all questions on back of page. So then you ask, have you ever ridden in a car driven by someone, including yourself, who was high or had been using drugs or alcohol? And you circle 1. Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? No or yes. Do you ever use alcohol or drugs while you are by yourself or alone? No or yes. Did you ever forget things you did while using alcohol or drugs? No or yes. Your family or friends ever tell you that you should cut down on your drinking or drug use? No or yes. Have you ever gotten into trouble while you were using alcohol or drugs? No or yes. So based on the answers now, then you go to the other products. Have you ever tried to quit but couldn't? Do you vape or use tobacco? No, because it is really hard to quit, and tobacco is one of the hardest ones to quit. Have you ever felt like you were addicted to vaping or tobacco? Have you ever have strong cravings? And it continues, right? So that screening tool is the one most recommended for adolescents. Okay, I'm trying to go back, hold on. To my screen. All right, you're seeing my screen still? Are you seeing the, what's my next slide? Are you seeing intervention now with the next slide?
Yes.
Okay, thanks. So how do we address these realities that we're facing? Thanks for that. We do prevention and we do treatment or counseling services. So all our prevention is evidence-based, and we try and use the international best practices as well for that. So we have prevention programs, we have drug education, we have demand reduction approaches that we use to kind of use the evidence and the efficacy of same to help us with the prevention. With treatment, you're going to have individualized treatments. I can't spell treatment plans there. You're going to use motivational interviewing, cognitive behavioral, brief SBIRT, especially for clinicians, and family therapy as needed. And there are other best practices as well, but in the interest of time. And then you need to also look at the other things that are happening to them. So the demand reduction approach, we speak of prevention. We want to reduce existing risk factor. We want to increase the protective factor, and we want the individual, and we focus on the individual, the high-risk group, family, and community setting. With treatment, we want to strategize to cope with or manage the drug use or misuse, cravings, and how to avoid relapses. And for us, the risk factors that we look at is what are some early antisocial behavior. Severe again, parental supervision. You hardly see kids that have a great relationship. But Dr. Leiber said, talk 1, listen 5, the 1 in 5 ratio, that have that relationship that children will be using substances or get into any deviant behavior. So the relationship is crucial to them becoming productive citizens. There's drug availability in every community, every corner shop, and there's no discretionary sale to minors. There's poverty that's driving it. The peers are doing it. They're failing. The poor risk perception, they have poor coping skills. And the culture is driving it. Our music, the parental involvement is what we have to increase on. We have to be consistently improve on discipline, get them more engaging, more meaningful activities. So the extracurricular activities at the community level, at home, acceptance of conventional norms. We need to change those norms. And if we get them bonded to the schools, the community, the churches, that will also let them feel important and special. So how we do what we do? We look at our programming. We do universal program that targets everybody. We look at indicated, that look at those persons that may have started using or at risk at using. And we do community prevention as well, where we come with what we usually do is select communities that we'll be working with for the year. And we're going to do a program within those communities. We're looking at the environmental factors, what it is, the legislation. So right now, we're starting again. We did a national household survey, and hopefully that will help drive the harmful alcohol use policy. The tobacco control regulations are being debated as we speak. And so we want to do more of that kind of legislation. The Prime Minister had given his word as well to change some of the Dangerous Drugs Act because it is limited in what it covers. So to expand it to include new psychoactive substances. Selective now, who can we target now that have started using? So we need to build their life skills. Family prevention programs, you'd want to increase the family bonding. We said that is critical for them thriving. So we have a family program. There are special programs that we do with child diversion, citizen security program, or the plan that they have now. And we also do drug rehabilitation, screening, testing, counseling in workplaces. And we use our community approach. We'll target this community and we'll flood it with all our interventions. It's look like my time is running out when I see your face comes up. But this is beyond prevention, right? And early treatment, we need to consider their level of intoxication, the presence of other medical conditions, of other emotional or behavioral problems, their readiness to change, risk of relapse and recovery. And when you're doing it, you need to consider the holistic care plan. I'm running through it now. And SBIRT is a solution that you can use, and we'll be willing to train you all in SBIRT. This organization could perhaps invite us to a training in that way. You look at screening and brief intervention for them and referral to treatment as needed. So what you want to do as well is to have referral to treatment, because only 5% of the cancer we are going to see, now the rest you will see. So we want you to refer with warm handing over. So you'll call us and tell us that so-and-so is coming, and then you let them know we are the place to go, or this is the other place to go. And these are some treatment facilities that are available. University Hospital of the West Indies, you have the Addiction Treatment Services Unit, Bellevue Hospital, some of the regional hospitals, mental health clinics, some psychiatrists, Richmond Fellowship is there, Teen Challenge, Rise Life, and of course the National Council on Drug Abuse. So 564 Help is where you can get the help that you need. These are our numbers across the country. So if you need us, you can call us. And I think that's it. So thanks.
Thank you so very much, Ms. Carlu. We certainly have appreciated all of this information that you've been sharing with us. And those last numbers and the agencies that we can contact, I'm going to ask you please to share that with us so that we can circulate it to our membership. I don't know if you can, if Sam can put it in the chat, or if you can just let us have those slides. Let us have copies of those slides so that we can actually circulate to everybody who's attended today. I just want to thank you for sharing this information on addiction disorders and the services that you have available at your client services department at the National Council on Drug Abuse. this task seems extremely difficult, and it seems scary. There is so much that we have to do. There is so much more that we doctors need to do to assist, to give information to the parents that we see, and to actually screen the children that we're seeing for other problems for this disorder. To hear when a parent says this child something changed in the behavior, they're withdrawn, to listen out for those cues that you shared with us. That's another slide you should share with us. They are no longer addicts. We need to be careful with our terminology that we don't label people of any form. And it is something to learn that 57% of the addicts and the people, those on substance abuse, are our children. That's an amazingly upsetting figure. 57%. How do we cope with this? You know, post-COVID, alcohol abuse, you say, up 40%, ganja abuse
No, it's
up
not up. Those
13
are the
use,
percentage.
and
Those are the real
tobacco use.
percentages. 40%. That's the real percent, not up.
Those are the real percentages, as yes. Those are as they exist now.
Yes, and the children
And
usually
then they're
70
not getting
something
any
percent.
guidance at home.
Right, right. The children, normally the
not getting
ratio
any
for children to
guidance.
adults in our treatment facilities, about 75%. But because of COVID, we're just getting them back into the system. We're very concerned, very, very concerned.
And we must remember your emphasis on our grade 10 students. What happens right then and there, where they have increased pressure both at home and at school. And then the other thing about our, this is anxiety, depression, suicidal ideation, and lack of parental guidance. And something else you said that might be up, sexual abuse at home. Really? This is up with the COVID. This is so distressing to hear. So,
Hey, Dr. Brown Morgan, we lost you there, but I think we're at the Q&A section.
yes, so we just want to thank you. And we're going straight into our Q&A, which we will have for the next 15 minutes. Sam, can you please address for me any questions that you see?
No questions online so far. Really just seeing wonderful presentations by everyone. There's a specific request, as you've identified, Dr. Brown Morgan, for this information to be shared in a quick grab that persons can refer to. So I know that Lynn and the team from CCFP Syrian, they'll be working on collating that. And of course, I'm sure Mrs. Carlu has shared the PowerPoint with the team from CCFP.
I'd just like to invite Doctors Leiber and Dr.
Jordan Eaton.
Dr. Jordan Eaton back to join us for a very, very short Q&A. Anybody have any questions? Put them in the Q&A now, or you can put your hand up and we will quickly acknowledge on these very, very concerning topics that we have shared: mental health and abuse, drug abuse today. No questions, Sam? Anyone want to get involved?
None that I'm seeing so far.
I have one question that I would like to ask, generally speaking, across the board of each person presenting today. And I think it comes from Dr. Eaton's presentation, where, we're using so many screening tools generally. And these screening tools are so good in making the diagnosis. Do we need us, or do we need AI to do the screening to actually identify and to make our lives easier and just identify for us those really at risk. I mean, AI can probably also then, based on what you're saying, give us the management. So, Dr. Eaton, your expressions first.
Okay, I am going to be slightly controversial. I am a child of the digital age, and I grew up cusping generations, and I'm very much one foot in each world. I dislike an over-reliance on artificial intelligence because, especially, AI has a place in science. Absolutely. Medicine is art and science. When it comes to mental health conditions, it is more art than science. We use screening tools, absolutely, but there is subtlety and there's nuance that we cannot even effectively articulate. There is, I'll never forget, there's a consultant that taught me that said, the patient has an affective flavor to them. And it's a je ne sais quoi, you can't explain it, but you know exactly what they mean. It is next to impossible to articulate some of these things. And AI is doing what we're doing already. It's asking questions, it's looking at patterns of behavior, and it is predicting behaviors based on that. But that's really what we're doing. The benefit of using AI, in my mind, I can't conceptualize it more than maybe scaling up. So where I would think AI would be beneficial, for example, would be in doing, for example, as Ms. Curlew had mentioned, the surveys. Can we employ AI in looking at the distribution and the rollout of using some of these screening tools, flagging up some of these cases and helping us to predict some of the behaviors and the patterns and the statistics and the data that can further guide our clinical practice? I don't think that we should really rely on AI to fix everything.
Yes. Well, we'd be putting ourselves out, I think, out of the equation. But anyway,
well, thankfully, psychiatrists are safe from AI for now.
Ms. Curlew, your take on AI in assisting you in what you do?
So I think AI is both good and bad, as Dr. Ethan mentioned. Certainly it will help us with gathering the data, maybe disaggregating it, giving us more information and pointing us where we need to focus on. But to help with the people, that's relational. And that's a computer or AI cannot replace at all. So it can help with diagnosing, it can even maybe suggest treatment modalities and all of that, but certainly not the fixing. And when you study psychology and counseling, one of the things that you note in advanced counseling is that you have about 50 modalities, 30, and they'll all work. But what makes it work more is the relationship you have, the therapeutic alliance with the client, and that you can't get with AI.
Thank you. Thank you very much for that. Dr. Leiber, I was wondering how AI could help us screen some of those apps, some of those apps that are being so negatively influential on our children. Is there a place for us to use AI? And where do you see this, Dr. Leiber?
Thanks, Dr. Brown Morgan. Yes, I think AI has a role in what I would call basic screening. I did not see any real screening tools for like social media, problems with social media. They're probably there, but I didn't see them. So I think that's where the role could be. I just give an adage that I've always worked by. It said that an average therapist gets the disorder, but the excellent therapist gets me.
Okay.
Right.
All right. Yes, thank you. Thank you very much. I'd like to thank uh, all our presenters this morning for being here. They've done a great job. They've shared with us what is almost toxic. I use the word toxic because of what we've been talking about. But it's a toxic area, toxic in terms of the harm it is doing, and in terms of our inability to properly address it. A lot of work to be done. So we want to thank you. We want to thank Dr. Eaton, Ms. Curlew, and Dr. Leiber for being with us this morning. And thank you also for answering our little questions here. I'd like at this time to ask Health 2000 Canada, H2K, to come on board and share with us. They are our sponsor today. I'd like to correct. Health 2K is our only sponsor today. They have that lovely role of taking us on and caring for us. And we'd like to share their products now.
Today, from Health 2000 Canada, otherwise known as H2K, a generic pharmaceutical company proudly serving you since the year 2000. I will be highlighting drugs available for sexually transmitted infections, yeast infections, and/or emergency contraceptive. H2K azithromycin 500 mg tablets, fast acting within 2 to 3 hours for the treatment of common respiratory infections such as pneumonia, bronchitis, skin infections, ear infections, and also high clinical success in genitourinary tract infections, including STIs, prostatitis, cervicitis, cervicovaginitis, and salpingitis. Did you know we also offer H2K's CASI 200 azithromycin suspension? It's a convenient once-a-day dose with a menthol minty flavor, enhancing compliance in children and the elderly. H2K acyclovir 400 mg and 800 mg dispersible tablets, the empirical choice for herpes simplex and outbreaks of genital herpes, shingles caused by herpes zoster, varicella zoster virus, including chicken pox. H2K acyclovir is also used for the suppression and prophylaxis of recurrent herpes simplex infections in immunocompromised patients, such as HIV patients and persons with weakened immune systems. H2K acyclovir reduces the itching and severity of outbreaks and prevents development of new blisters, reduces time until healing and time until clearance of lesions. It is well tolerated and starts working as fast as 24 hours after the first dose. H2K acyclovir 5% cream, stop cold sores in its track. H2K acyclovir 5% cream treats cold sores and fever blisters from herpes labialis, as well as treating at the first sign of genital herpes. H2K acyclovir cream speeds up healing of the sore and decreases symptoms such as tingling, pain, burning, and itching. To use H2K acyclovir cream, apply a small amount up to 5 times per day on infected areas or as prescribed. H2K Emerge Pill, levonorgestrel 0.75 tabs. When accidents such as condom breaking, missed birth control pills, or unprotected sex happens, emerge the morning after emergency contraceptive pill taken within 72 hours. The second pill is taken 12 hours after the first pill. Emerge works by preventing a woman's egg from fully developing. It may also prevent the attachment of the egg to the wall of the uterus. Patients should speak to their pharmacist about getting Emerge over the counter. H2K fluconazole 150 mg, the 1-day 1-dose success in vaginal candidiasis, acute, recurrent, and prophylaxis to reduce the incidence of recurrent candidiasis. Also for oropharyngeal candidiasis, esophageal candidiasis, other candida infections including urinary tract infections, peritonitis, as well as candidal balanitis. H2K fluconazole works by targeting the underlying infection and flushing out the discharge, thereby significantly reducing symptoms and severity in 3 days treatment. However, depending on the infection and the severity, it may take 1 to 2 weeks or more to work fully. Thank you for listening. Please support by writing H2K before the drug name on your prescription. Follow us on Instagram at Health2000 Canada to get tips and information on our over-the-counter products that will be useful for your patients and even yourselves. Thank you.
Good to have H2K with us today. Your products are very, very relevant to the topics that will follow. And therefore, and I just want to thank our presenters again today because they have been phenomenally good. And we have learned much about ourselves and as well as about our patients. So thank you, ladies and gentlemen, doctors. And it is now my privilege and pleasure to hand over the moderating of this webinar to my esteemed colleague and family physician, Dr. Pauline Williams-Green, at this point in time.
Thank you, Arno. I'm receiving the baton, even as you hand it over. And you are ahead of the game. We are ahead of all the other persons in the lane, and we're ready to go. If you haven't already, please stand and stretch, do your deep breaths, and let's get ready to continue a fantastic seminar on adolescent health. We have been led ably by Dr. Anna Brown Morgan, and I am honored to take over as we start again. Our next section will focus on other concerns of adolescents. We will start with allergies, asthma, and sleep apnea. And who better than to do this than Dr. Paul Scott? He is a lecturer, internist, consultant physician, and well-known pulmonologist here in Jamaica. In fact, he pioneered sleep investigations in Jamaica, and he has done so since 1999. He's an award-winning presenter and a dear friend as well. And so, if Dr. Paul Scott is on, we're ready for you to share your slide and get going as we look at the topic, allergies, asthma, and sleep apnea. I kind of like the alliteration, AAA. All right, Dr. Scott?
Hi, Dr. Williams-Green. This is Sam. Unfortunately, I'm not seeing Dr. Scott. He was on with us earlier. I'm not sure if he's having internet issues. I will try to reach out to him off air. Please move on to Dr. Walker while we try to get Dr. Scott back on.
All right. So, Dr. Walker, Dr. Leo Walker, we're going to welcome you. And Dr. Leo Walker shared his profile with us. And this is to continue to provide outstanding holistic care with a detailed and dedicated approach while maintaining communication and confidentiality. Thank you for that. More alliterations, Dr. Walker. He is a graduate of our university here. And after doing his Bachelor of Medicine and Bachelor of Surgery, he went on to do obstetrics, and he obtained honors in obstetrics and gynecology. He then did a fellowship in maternal fetal medicine at the University of United West Indies. Not sure, tell us a little bit about that, just as you start, please. And he highlights for us the skill of being one of the few certified O-shot providers in Jamaica. So I'm very intrigued. What is an O-shot provider, Dr. Walker? So he's going to tell us about this, and his topic is adolescent reproductive health challenges. In particular, he will look at STIs and endometriosis. Dr. Walker, go ahead and share.
Hi, morning. Morning, and thanks for having me this morning. Let me just bring up my presentation quickly. Alrighty, so there's a question about the O-shot. The O-shot is actually an injection of platelet-rich plasma, which is administered in the vagina and the clitoris to improve sensation, but also to improve lubrication. It's also one of the notable treatments for stress urinary incontinence. So it has multiple uses, but predominantly is used as a means of sexual enhancement. Give me 1 second, my computer is asking for a password, just 1 second. Okay. So let us begin. So I was given the task of going through the topic of endometriosis as well as a little bit on sexually transmitted infections. So I'll try to see if we can go through as quickly as possible, but as comprehensive as possible. So endometriosis, what is endometriosis? It's simply defined as the presence of endometrial glands and stroma outside its normal location, which is in the uterine cavity. Endometriosis is hormonally dependent disease, and as a result, is chiefly found in a reproductive age women. So as a woman enters puberty and her estrogen production increases, so does the onset of endometriosis, and further progression will occur through a woman's natural fertile life. So I always like to compare the uterus to that of a papaya. The shape is extremely similar, and the structure is pretty similar as well. The outer surface of the papaya is like the serosa of the uterus, where the actual fruit or the meat of the papaya is similar to the myometrium, or that muscular layer of the uterus. And the endometrium is almost like the seeds of the papaya. Now, just imagine a papaya now where the seeds are actually found on the outside, on the surface of the skin of the papaya, but also along the branches of the tree. This is essentially what endometriosis is, the presence of hormonally active or dependent endometrial deposits in locations outside the endometrial cavity. Now, the incidence is difficult to quantify simply because there are a lot of patients who have endometriosis who would have never sought medical attention, or patients who have chronic pelvic pain for which the etiology was not explored. The annual incidence of surgically diagnosed cases, however, is around 1.6 per 1,000 women aged 15 to 49 years. And among asymptomatic women, the prevalence of endometriosis ranges from around 2 to 22%. That's pretty significant, almost as high as 1/5 population of reproductive age women. Now, among infertile women who are investigated for the causes of infertility, the prevalence was found to be between 20 and 50%. So almost half of women who have fertility issues would be diagnosed or would potentially be diagnosed with endometriosis. Now, what is the pathogenesis? Now, the most common and consistent theory associated with endometriosis is Sampson's theory of retrograde menstruation. Now, upwards of 90% of women will experience some degree of retrograde menstruation. Now, what this simply means is instead of 100% of that blood and endometrial deposits and fluid passing through the cervix and the vagina, there is a small percentage that actually flows back through the tubes and deposits itself within the peritoneal cavity and the structures therein, which would include the surface of the bladder, the surface of the rectum, and of course the ovaries. Now these reflux endometrial fragments adhere to these structures. Now, people might be asking, well, if so many women experience retrograde menstruation, why is the incidence of endometriosis not higher? Well, this is simply because the pathogenesis of endometriosis is more of a combination of factors as opposed to one factor in isolation. This is where now we have the role of the immune system. Now, what would normally happen is one's immune system will act to remove these ectopic deposits of endometrium and clear it so that it will never adhere to the surface and never become and remain hormonally active. However, most women, as I said, experience retrograde menstruation. However, not most women will develop endometriosis. The menstrual tissue, which is refluxed into the peritoneal cavity, is usually cleared very easily by white blood cells. But there is a defective immune response, which is possibly responsible for the persistence of these endometrial deposits and therefore the genesis of endometriosis. There's also the role of what we refer to as vascular or lymphatic spread, which would account for the presence of endometriosis in distant sites, most notably the lungs. There are women who, with each cycle, would experience bleeding within the tissues surrounding the lungs and actually may present as a medical emergency. There's also a tendency for endometrial adenocarcinoma to spread via the lymphatic route, which indicates the ease with which the endometrium can be transported via this route. There's also a not as popular theory called the theory of coelomic metaplasia, where the surface or the cells which line the peritoneum actually have the potential to transform into tissue which histologically resembles that of the endometrium. And of course, not to forget the importance of genetic or familial clustering, which increases which we see has an increased incidence of endometriosis among first-degree relatives, which suggests that there is some pattern of inheritance. So women with endometriosis who also had an effective first-degree relative were more likely to have severe endometriosis than women without a first-degree relative. Now, what is the pathologic appearance of these endometriotic deposits or these deposits? Now, these may actually develop anywhere within the pelvis and any other extrapelvic site. The ovary, as well as the structures posterior to the uterus, are frequently involved because this is really where the fallopian tubes are oriented to the posterior uterus. So most of those structures posterior are often the ones which are more commonly affected. So the ovaries, the surface of the rectum, and that potential space behind the uterus, what we refer to as the retrouterine pouch of Douglas. This again has implications on the type of symptoms which women would experience as a result of endometriosis. So just a very simple graphical representation of the potential sites or the more common sites within the pelvis where you have these deposits of ectopic endometrium. Now, the pathological appearance can vary widely. Typically, small raised either red, brown, white, or blue spots on the ovarian surface with fibrinous adhesions. But when there's deposits on the ovary, there's also the potential for the development of endometriomas as a result of repeated hemorrhaging within the ovary. So every month, because these deposits are hormonally active, they also bleed, much like the normal endometrium would bleed. And as a result, there is bleeding or hemorrhaging within the ovary itself, which results in an accumulation of blood and development of these chocolate cysts. So again, this is just how one would visualize endometriosis on laparoscopy. And we can see the varied appearance of the deposits. These are usually the typical blue or brown-white deposits that we'd see on the uterus and adnexa. And of course, we have a little bit more in terms of brown, even almost a dark blue type of purple appearance. And this is essentially what the chocolate cyst would look like. I mean, the name itself is self-explanatory, but what you have is bleeding, repetitive hemorrhaging within the ovary, and an oxidization of the blood. So it gives us this thick brown chocolatey appearance. Now, in terms of the classification system that we use for endometriosis, really was developed by the American Society of Reproductive Medicine. It's not a very popular classification system, but is one that we would often widely use, particularly at the time of operative laparoscopy. The purpose of it was really to predict chances of conception based on the severity of the disease. How many of the tissues are involved, involvement of the ovaries, whether or not the ovaries themselves are affixed to one another, referred to as kissing ovaries. So the classifications looks at the extent of endometriosis among organs and within an organ, scoring of superficial versus invasive disease, meaning is the endometriosis just involved in the surface of the tissue, or is it deeply penetrating into the walls and sometimes into the lumen of the tissue? This is with specific reference to the bladder or the rectum. The size of the endometrium or chocolate cyst, and the development of endometriosis bilaterally on the ovary, as well as the type of adhesions that we're seeing, whether or not these are very thin, filmy adhesions, which are very easy to break down, versus whether or not these are very thick, bulky adhesions, which require extensive adhesiolysis. No, really, this is just the form that we use as a guide when we're actually classifying endometriosis. Just placed there to give everyone an idea of what it is that we do in terms of the scoring system that we use. Now, the cumulative score results in a stage designation of the disease. The problem is the reproducibility of the classification system being very limited, as it will vary from one operator to the next. So it's not very objective. There is some subjectivity to it. And therefore, for that purpose, it is somewhat flawed as a classification system. The clinical presentation, patients will often present with pain, which is either cyclic, meaning happening monthly, usually around the time of ovulation, which often is around 2 weeks prior to the onset of the period. Or it could be just chronic pelvic pain, which is pain on a daily basis for a period of greater than 6 months. Now, majority of patients with endometriosis will tell you that they do have chronic pelvic pain, meaning they have pain on a daily basis and they never have, or they rarely have pain-free days. Pro-inflammatory mediators released by endometriotic implants into the peritoneal fluid is usually responsible for this chronic pelvic pain, but there's also occasionally neuronal invasion of these endometriotic deposits. Remember, within the pelvis, there's a lot of nerves and nerve bundles, and occasionally you do have infiltration of these endometriotic deposits very deep into these nerve bundles, which again can precipitate this very chronic pain. Pain when passing stool, pain when passing urine, pain during intercourse, and just pain even while doing nothing at all. Again, dysmenorrhea is pretty common. And the type of dysmenorrhea is usually what we refer to as a congestive type dysmenorrhea, which is different from the spasmodic type of dysmenorrhea that women may experience secondary to uterine fibroids, where they have very heavy menstrual blood losses. Spasmodic in that as the blood or clots are passing through the cervix, that is usually when they experience majority of their pain, as opposed to patients with endometriosis, where their period pains usually start again in and around the time of ovulation, typically 2 weeks prior to the onset of menses. And this is something which continues up to the point that the bleed has started, and sometimes even beyond. Of course, dyspareunia is also very common, again, because of involvement in that retrouterine pouch of Douglas, that significant scar tissue, as well as the relative immobility of the pelvic structures. Dysuria, pain when passing urine, and this is most often secondary to infiltration, either the surface of the bladder or within the actual bladder tissue itself. And of course, dyschezia, less common, but maybe chronic or cyclical, associated with constipation, diarrhea, as well as sometimes even blood in the stool. As I alluded to earlier, almost 50% of patients with infertility will also have endometriosis. So this is it's no surprise that infertility is among one of the clinical presentations of patients with endometriosis, simply not just because of the involvement of the tube itself, but because of these inflammatory mediators which are circulating, which can inhibit sperm activity, but also transport of the egg. So how do we make the diagnosis? The truth is, for majority of cases, the diagnosis is going to be clinical. And this is really because doing diagnostic laparoscopies, I mean, there's obviously affordability issues. So majority of the patients that we see, we do make the diagnosis of endometriosis based on clinical findings. That is history, examination, plus or minus investigations, which is usually in the form of ultrasound, not necessarily to visualize endometriosis or the deposits themselves, more so to visualize the sequelae of endometriosis. So large endometriomas, retroverted uterus, immobility of the pelvic structures themselves. So in terms of on inspection, we can visualize deposits, whether they're in surgical scars. So for example, patients who have had previous surgeries, either previous laparoscopies or laparotomies, sometimes those deposits can embed themselves within the surgical scar, and there's bleeding as well as repetitive wound infections at that site. For patients who have delivered vaginally and had episiotomies, same can occur at these episiotomy sites. On speculum examination, we can occasionally visualize those discolored deposits on the cervix or within the posterior fornix of the vagina. And of course, we can occasionally feel nodularity of the uterosacral ligament. Again, that ligament is at the back of the uterus where majority of your deposits will find themselves. And therefore, on examination, we can actually appreciate that. Of course, if large endometriomas are present, we can appreciate that fullness in the adnexa. And patients usually tend to have very exquisite tenderness in the adnexa as well. Now, the endometriomas can be diagnosed pretty easily on ultrasound with adequate sensitivity in most settings. And it's usually described as multiple low-level internal echoes within the ovary, meaning we can actually visualize this accumulation of blood within the ovary itself. The ovary is relatively immobile, and occasionally we'll see those two ovaries almost affixed to one another, what we refer to as kissing ovaries. The gold standard for diagnosis, however, is of course diagnostic laparoscopy and biopsy, meaning we obtain a sample of the lesion, send it to the lab, and they confirm it as ectopic endometrial tissue. The findings at the time of laparoscopy are quite variable and may include discrete endometriotic lesions and endometrioma, as well as adhesion formation. The one thing that's important to note is we often find that there is a disparity with the severity of endometriosis and the clinical presentation. By that, I mean you do have patients who have mild endometriosis based on the staging system that we use, but have very severe symptoms. And conversely, we have patients who have severe endometriosis, but have very minimal symptoms. So the symptomatology itself does not always correlate with the severity of the disease. Let's get a little bit into management. Now, endometriosis should be viewed as a chronic disease that requires lifelong management plans with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. Treatment decisions are often individualized based on patient symptom severity, extent of disease, location, of course, reproductive desires, which tend to go hand in hand with patients' age, side effects of the medications, as well as cost of the interventions that we're recommending. But generally speaking, among medical managements, we have these classes of drugs which we often tend to use. Of course, painkillers, which are usually in the form of NSAIDs, or combined oral contraceptives, or progestin-only contraceptives. Mifepristone, which is a selective progesterone receptor modulator. And for patients who have very severe, persistent, and unrelenting disease, we often have to rely on our GnRH analogs, such as leuprolide or aromatase inhibitors, which I would say isn't used very frequently in the management of endometriosis, but Among this list, you'll often see us employ the use of NSAIDs, COCPs, or progestin-only contraceptives, and most notably, or GnRH analogs. Now, surgical management largely involves adhesiolysis to restore normal pelvic anatomy, but also removing any of the obvious deposits that we can see. Now, because the primary method of diagnosis of endometriosis is laparoscopy, we can often use that as an opportunity to perform an operative laparoscopy, restore some normal pelvic anatomy, remove those deposits that we can visualize, and try to minimize any risk of injury to any of these surrounding structures. Adhesiolysis is postulated to effectively treat the pain symptoms in women with endometriosis by restoring that normal anatomy and mobility of the pelvic viscera. Hysterectomy with bilateral oophorectomy is an option as well. I mean, what we find most of the times is because endometriosis predominantly affects women of childbearing age, it's not really a viable option among majority of the patients that we see, because preservation of fertility for that particular, or for those particular patients, is of course one of the primary goals. It is, however, the most effective therapy for women with endometriosis who do not wish to retain their reproductive function. For women who undergo hysterectomy alone, there's actually a 6-fold increased risk of recurrent pelvic pain and an 8-fold increased risk of repeated surgeries. And this is simply because the ovaries are still there. The ovaries is the primary source of estrogen production, and estrogen is what drives further progression and activity of those endometriotic deposits. Of course, if there is an obvious endometrioma, the goal is to resect it, not necessarily to remove the ovary, but to remove the endometrioma and leave that normal ovarian tissue behind. And one of the more extensive treatments is what we refer to as presacral neurectomy, which is simply dividing some of those nerve bundles in the uterosacral ligament or in the posterior pelvis to reduce that chronic pain which patients may experience, particularly if uterosacral ligament is heavily involved. Complementary therapies, of course, lifestyle modification cannot be overlooked. We have one study that reports a lower risk of developing endometriosis among women who have a high intake in green vegetables and fruits, with an increased risk of endometriosis among those individuals who consume heavily red meats. One randomized trial had also demonstrated that the use of acupuncture was effective in treating dysmenorrhea in women with endometriosis. So we don't want to discount non-pharmacological and surgical treatment methods. There is a role for lifestyle modification, diet, exercise, and also the use of acupuncture. Any questions at this time? All right, so if there are no questions,
well, we're actually going to have question and answer at the end,
okay,
Dr.
No
Walker.
problem. No problem.
Somewhere around 2:15, if not before, we will ask questions.
No
Thank
problem.
you. That was a very riveting presentation. I really enjoyed it.
We're only halfway, so we're moving
we're
on
looking
quickly
forward now. Okay.
To vaginal discharges, but predominantly STIs. I'm going to touch on the management in both the gravid and non-gravid patients. So, introduction, vaginal discharge is a frequent presenting complaint in any medical practice. Majority of patients who present to the gynecological outpatient department will be complaining of a vaginal discharge, as it can be quite bothersome for a patient, with vast majority of women presenting their reproductive years. The degree of distress in us is often subjective, but it's also related to the underlying etiology of the discharge. Some may be annoyed by the slightest discharge, while others have no complaints despite a marked discharge. Now, symptoms and physical signs may generally be sufficient enough to distinguish between specific etiological agents. However, on occasion, we may need to employ the use of adjuncts to actually diagnose the underlying cause. There is often a strong temptation to treat solely on the basis of the clinical appearance without confirmation through lab tests and cultures. And where this may be applicable in certain scenarios for others, this approach may actually lead to either treatment failure and recurrence of these discharges. Now, when considering the cause, it is useful to distinguish between non-infectious from infectious causes. So I'm going to just briefly jump into some of the physiological changes, because by understanding some of these physiological changes, we can avoid unnecessary treatment of patients and or over-treatment of patients. So in the normal cycle, there is noticeable dryness of the vagina shortly after menses stops. This is quite normal. It's related to the fact that most of those hormones are usually produced at the beginning of the cycle. Now, under the influence of rising estrogen and progesterone levels, the cervical glands now start to secrete an increasing amount of clear mucus. And this usually peaks by around mid-cycle, where ovulation usually occurs, where the discharge is noticeably different. It's a lot more mucoid, a lot more stretchy, what we refer to as spin barkettes. Following ovulation, the mucus becomes viscous, largely disappears, and a clear whitish discharge predominates. Pregnancy, of course, because of, again, hormonal fluctuations, can also affect the volume and composition of the vaginal discharge. So quickly, non-infectious causes, there's menstruation, obviously. These physiological changes throughout the menstrual cycle can produce secretions from the cervix and the vagina, which can cause an unusual vaginal discharge, meaning not something that women will often see throughout their cycle. Following menstruation, there may be a brownish discharge, which simply will represent some of that old endometrial blood that is now mixing with the normal vaginal discharge. But on initial inspection might be difficult to distinguish from a discharge caused by a vaginal infection. So it's always important to tell patients that immediately following the period, even though majority of the bleeding has stopped, there may be some discoloration of the discharge, but this is just as a result of some old altered endometrial blood that is mixing with the vaginal discharge. Of course, sexual activity may result in the introduction of semen in the vagina. Semen, in contrast to the vaginal discharge, has a much higher pH, and this can disrupt the normal vaginal environment and result in the development of bacterial vaginosis. So it's important to distinguish or make the distinction that bacterial vaginosis is not a vaginal infection, but simply a change in the vaginal discharge, which results in predominance of another type of bacteria in the vagina called Gardnerella vaginalis, which thrives at these higher pH levels. And once we have this excess Gardnerella vaginalis, there will be no way the development of bacterial vaginosis. So jumping into now infectious causes, which of course, by a long shot are the more significant ones. In the overwhelming majority of cases, an abnormal vaginal discharge is caused by Candida albicans. Less common causes include pathogens like Neisseria gonorrhea, Chlamydia trachomatis, as well as herpes simplex, both 1 and 2. For effective treatment of any of these organisms, precise identification is crucial, since some of the symptomatology may actually overlap. So firstly, we'll talk about candidiasis or yeast infections. Candida albicans is the predominant yeast isolated from the vagina in the context of these infections, accounting for up to 90% of cultures. Of course, there are other non-Candida albicans species which can cause yeast. As a matter of fact, Candida organisms can be isolated as part of the vaginal flora in about 20% of asymptomatic women. So even among women who are asymptomatic, there is some amount of Candida organisms present in the vagina. Now, several host factors has been associated with increased predisposition to Candida infections, such as diabetes, pregnancy, antibiotic use. You see a lot of the times patients following a course of augmentin for some other cause may develop yeast infections, corticosteroid therapy, as well as immunosuppression. Of note, there's also evidence to suggest that individuals of Asian ethnicity may also be predisposed to candida infections as a result of a particular protein that they like referred to as mannose-binding lectin. Occasionally, despite elimination of predisposing factors, some women continue to experience recurrent symptomatic infections. Identification and strain differentiation techniques suggest that post-treatment persistence of organisms in low numbers within the vagina may be responsible. So on occasion, we will often treat yeast infections with our azoles, the most notable one being fluconazole, which is sufficient for a majority of our Candida albicans species. However, there may be some resistance with our non-Candida species to fluconazole. Generally speaking, this is how the discharge would appear. And usually, patients would complain of significant pruritus, vaginal itching, irritation. Dysuria and dyspareunia can occur, especially if the intensity of pruritus is such that has led to excoriations on the surface of the vulvar skin. But the main signs are vulvovaginal erythema or redness, which may extend to the perineum and occasionally causing a lot of swelling in very severe infections. The discharge is commonly cream-colored and curdy, resembling cottage cheese. So this is usually, one which is pretty easy to diagnose, just clinically, just on observation of the discharge as well as the patient's complaints.
Hi, Doc. Sorry, 1 minute left.
Okay, thank you. Plaques of discharge often adhere to the inflamed vagina. The diagnosis can also be made on examination. Let me just breeze through quickly. And of course, as I mentioned, the treatment is mainly through azole therapy, either systemic therapy or clotrimazole inserts. Trichomoniasis caused by Trich vaginalis is a flagellated protozoa which attaches to the mucous membranes. Prevalence varies from around 20% of patients in the outpatient department to as high as 75% among sex workers. And 50% of cases are actually asymptomatic. When the symptoms are present, patient often complains of purulent, smelly, green discharge, which is often frothy in appearance, which can be mistaken for bacterial vaginosis. So therefore, the discharge itself cannot be used as the sole diagnostic tool. Patients often present with the characteristic strawberry cervix, and up to 20% of patients have dysuria. Of course, it's important in terms of the pregnancy-related morbidities because it is a notable cause of preterm labor and preterm premature rupture of membranes. The diagnosis is made predominantly via microscopy. However, we do have cultures which we can use, which can detect trichomoniasis. It's often something that we may also see on pap smear results, just on identification of those flagellated protozoa on the slide. Treatment is through the use of metronidazole. 2-gram regime is associated, 2-gram stat dose associated with lower cure rates, so therefore we'll often treat patients with 500 BD regime. BV, we had mentioned a little bit before, often associated with this watery, frothy vaginal discharge, which usually has a fishy odor. Again, not necessarily an infection, but it is associated with sexual intercourse as a result of introduction of semen, which often has a higher pH in the vagina. Diagnosis is usually made through the use of Amsel's criteria, and treatment again is through the use of metronidazole. Just quickly, going to touch on gonorrhea. Gonorrhea continues to be a major source of pelvic inflammatory disease. Of course, it's caused by the organism Neisseria gonorrhea. And again, there is a percentage of patients which are actually asymptomatic, up to 20%. Often presents with a mucopurulent cervicitis and urethritis. And most common symptoms usually follow an incubation period of around 2 to 10 days, and increased vaginal discharge, dysuria, and urethral irritation are common presenting complaints. The diagnosis is usually made through the use of nucleic acid amplification testing. We often do a high vaginal swab, well, not often a high vaginal swab, but a cervical swabbing, so we can actually obtain samples for testing. The preferred treatment regime is our ceftriaxone 500 IM. For those individuals who are greater than 150 grams, we'll often double the dose, so we give them a 1 gram IM dose. Of course, you do have alternative regimes, the use of gentamicin and azithromycin. And finally, chlamydia, one of the more insidious organisms, because again, up to 60% of patients are asymptomatic and may not have much symptoms to begin with. The most common symptom is some dysuria, some mild low abdominal pain, and very rarely a mucopurulent vaginal discharge. Treatment is often through the use of doxycycline, 100 BD per week, although a single dose of azithromycin can be used, and it's often associated with better patient compliance. I think we're out of time.
Yes, we're
So
out of time. So we will
I will
ask
just
you
pause
to.
there.
Yes, I think we'll ask you to probably mention it in the question and answer section, Dr. Walker. I will ask you about the herpes.
No problem.
All right. Sam, who do we have next, please?
Dr. Paul Scott.
All right. Dr. Scott, I've already introduced you as the pioneer in sleep technology in this country. So sleep investigations. And so your topic has already been announced: allergies, asthma, and sleep apnea. And we just want you to go right ahead so that we can have time for question and answer, both for Dr. Walker, yourself, and the other presenter. Dr. Scott, please start your slide sharing.
Yes, good afternoon, and thank you so much for giving me the opportunity to be here with you. I apologize for my video. My video is what held me back. It's not allowing me to start. I hope I can screen share. Let me try that again. Are you seeing my screen?
Yes, Doc.
All right, great. So I'm going to be talking about allergy.
Slideshow mode.
Yeah, it's a little slow today. I'm not sure why, but yeah, I'm getting it there. But it's there we go.
There you
go. So yes, thank you all for the opportunity to be here. Thank the Caribbean Association, or the Jamaica chapter of the Caribbean College of Family Physicians, for having me. Certainly an opportunity for me to speak on the topics I love a lot, asthma and sleep apnea. I'm going to go straight into my talk. I'm going to focus, as I said, to outline and identify the adolescent group, to highlight some of the important issues associated with particularly asthma and sleep apnea. I'm not going to say much about allergies despite the topic, but I'm going to focus predominantly on asthma and sleep apnea as it relates specifically to adolescents. So in any discussion on asthma, we can't discuss it without going back to the basic definition of asthma, since it provides us with all aspects of its presentation. So highlighting again that asthma is a chronic inflammatory disease, emphasis on chronic, emphasis on inflammation. And it results in two clinical aspects to its presentation. One is reversible airflow obstruction, which is what we hear with a lot of wheezing and so on. And the second aspect is the bronchial hyperresponsiveness. So a chronic inflammatory disease with reversible airflow obstruction and with bronchial hyperresponsiveness. So if we were to look at a slide, again, going back to asthma, we see the major differences between the normal airway and the asthmatic airway. So here we see that one, the smooth muscles are markedly hypertrophied in the asthmatic airway compared with the normal airway. We see that there's a tremendous increase in mucus glands in these airways, making these asthmatic produce lots and lots of mucus compared with the normal airway. We see that there are tons of inflammatory cells present throughout the asthmatic airway, which is not typically seen in the normal airway. And this results in the significant presentation that we see. And here I would like to highlight also the fact that the asthmatic airway, because of both the inflammation in the lining, the hypertrophied muscles, and the marked increase in mucus production and mucus glands results in a narrowing in that airway and the manifestations that we're so familiar with. So that's asthma. Now, when we look at the adolescent group, we're looking essentially at what we would typically call teenagers. And the WHO defines the adolescent age as 10 to 19 years. And you can put a little bit before that and a little bit after that in terms of our clinical practice in what we actually see. But typically, it refers to the teenage years. And the teenage years include essentially the period of puberty, a period of fairly rapid increase in physical size, emotional issues that we've heard about before earlier today, psychological issues which we have heard about earlier today too. And one of the things I want to highlight is that I always tell when I meet with young people that the best period of my life was my teens. And then the teens look at me and say, well, they were looking forward to something else because this is certainly not what they're looking for. But I think the best period of life is the teen years. It's the years when you achieve tremendous physical growth. And as we hear earlier, when you feel almost as if you're beyond reproach with any physical limitation. The physical accomplishments most would occur during this period. Academic accomplishments would occur during this period. For those of us who are here as doctors, this is the period of time when we got our qualifications that allowed us to enter university and allowed us to become medical practitioners. So it is a very important part of our career. And if you miss out on this period, you then end up falling behind because society is really geared at academia in terms of university entrance during this period. And then, of course, you can always go on to your postgrad and so on. So it's a very important period of physical accomplishment, very important period of academic accomplishment, and of course, emotional development, as we heard earlier also. The adolescent has a greater autonomy. They have a kind of confused state because they remain relatively dependent since they're not earning money at this period, but they begin to develop more physically and emotionally, and of course do get some degree of autonomy as they are prepared to enter the adult world with the technical definition of adulthood based on adult suffrage starting at 18. So again, there we see an overlap with what we call adolescence going up to 19 and adulthood, which by adult suffrage and vote starts at 18. But they still require guidance and they still require parental input. And therefore, it's important that parents recognize that even though adolescents are developing in a period when we give them more autonomy, we still have to overlook their development. So as we look towards asthma, many children with asthma will have actually fewer and less severe symptoms as they enter puberty into adolescence. And this is because their airways, they grow. This is a period of tremendous physical growth. And the airway that we saw earlier will grow. And the flow through the airway increases tremendously with even a small increase in the size of the air passage. And the common equation that I often quote is the fact that flow through a passage is proportional to the radius raised to the fourth power, for those of us who remember our physics. So even a small increase in airway size results in a tremendous increase in flow. So many children, as they get older, the symptoms of asthma get far less. So they no longer get the wheezing, and adults no longer hear the wheezing. It actually gets less severe. And in fact, sometimes people say they have outgrown their asthma. So patient and family may therefore be of the opinion that, hey, the asthma is gone. I've outgrown my asthma. And this, of course, we're all aware is a common misunderstanding. So these adolescents are still asthmatic, but their asthma impact may have changed a bit. They still have triggers, but the impact of the triggers is less because there is less airflow limitation. And it may still be sufficiently severe, however, especially if they get a significant trigger that they may enter the emergency room. But for anybody who has asthmatic children, they will recognize that the frequency of emergency visits to doctors and to the emergency room significantly fall off as the child gets older. And it's really just a natural increase in the airway and not that the asthma has gone away. So the rapid increase in airway and lung capacity says result in marked improvement in flow based on radius of the airway, and therefore simply growing bigger, simply getting older, simply moving from a child to an adult to adolescent age group makes a change in their asthma. So this is good, but it, as we said, may lead to a false sense of asthma resolution, leading to problems with compliance. So initially we may, the child may, and the parent may actually insist on compliance with medication, but seeing that the child no longer seems to have the attacks as frequently, will slack off a bit in ensuring that there's compliance. And as a result of that, asthma, the underlying inflammation in the airway may actually worsen during adolescence simply because the person is not using their medication regularly, but the impact on the person is less because they have less acute episodes of wheezing. Now, airflow symptoms, therefore, may become less prominent in patients entering adolescence, but what they're still left with is the bronchial hypersensitivity symptoms. And these may become more prominent, as we said, especially if there's a problem with compliance. So adolescents transitioning one may no longer feel comfortable. So in addition to the airflow changes, adolescents, they no longer feel comfortable seeing a children's doctor. So they actually many times may stop going to their regular doctor. So that happens, of course. And we know the reverse also happens sometimes where these adolescents grow up into adults and still continue to see their children's doctor. But sometimes they just don't like going to little people doctors. They want to go to big people doctors. So they may want a change in their doctor. And a change in doctor may not necessarily result in a formal transfer. So a patient may move from, let's say, a pediatrician to a more adult doctor, and there isn't a formal transfer. So information has been lost. And also the diagnosis may change because the pediatrician had been seeing the child with the recurrent episodes of wheezing, diagnosing asthma. And because the symptoms have changed and become predominantly bronchial hypersensitivity driven, you may find that when the adolescent goes to a new doctor, a new diagnosis comes up. And this may then again lead to problems with treatment and problems with diagnosis. So there is a kind of mixture at the adolescent transformation where the asthma seems to get better, but at the same time, aspects of the treatment may deteriorate. So the potential impact of poorly controlled asthma, of course, is that there may be a resurgence of symptoms, but I'm going to point out in another slide, this slide here, that the symptoms may vary. It may result in poor sleep and sleep disturbance. And I'm going to talk a little bit more about sleep also as it relates to adolescents. It may result in poor school performance. Poor sleep, sleep disturbance may result in excessive daytime sleepiness, and therefore adolescents or young children or at the high school level may actually fall asleep in class, or even if they don't physically fall asleep, they're not very attentive because they are sleepy and therefore may not be concentrating on what's happening in the classroom. So they may also have an inability to participate in sporting activities and may underperform in these sporting activities. And we are quite aware, certainly as a country, Jamaica, where sport is a very important aspect of academic development for many students, because this is what they rely on to get their scholarships to go overseas. They may underperform in sports, and because they underperform in sports, they may lose academic opportunities overseas. So it's not good enough to just simply say whether they're studying hard enough or not, but we have to recognize that being a sporting country, opportunities also come through sport. So sport development and physical development is important in adolescent development. Now, a few things to remember that up to a third of asthmatics will have symptoms exacerbated by physical activity. That is, they have exercise-induced symptoms. So even if they don't seem that significantly impacted, when they go to the physical activity, it may result in bronchial responsiveness and airway narrowing. And this can impact their performance and even their willingness to participate in training. Also, remember that the estimated prevalence of asthma in our population, this is across the board, not just adolescents, is roughly 20%. So a significant number of our population would be asthmatic. A significant number probably go undiagnosed, and a significant number will therefore not be adequately treated. So let us look at some of the symptoms of asthma. And here I try to break them down into what would be airflow-related symptoms on the left and bronchial hypersensitivity symptoms on the right. So we said that the typical airflow symptoms that we're commonly associated with is wheezing, dyspnea, chest tightness, of course. And of course, where we do peak flows on these things, we'll see low numbers. And this is what we're quite familiar with. And from a pediatric point of view, this is what we will see with our younger children, you know, the 8 and 9, the 10-year-olds. When they get into adolescence, and of course, especially when they pass through puberty and they get a physical increase in size, these symptoms may actually be reduced. And this is where we get the feeling that they have outgrown their asthma, but they still have the bronchial hypersensitivity. They still cough, and the cough may occur at night because of temperature fall. They still have exercise-induced symptoms. So they get chest tightness when they do physical activity and may shy away from physical activity. They still may be sensitive to a number of things, including odors and temperature. And so the bronchial hypersensitivity or the bronchial hyperresponsiveness aspect of the symptom is what becomes more predominant in the adolescent asthma versus the younger child asthma. And we have to be aware of this shift and recognize it. Otherwise, we will clearly miss and undertreat our asthmatic. So once we have asthma, we said that we have to look at severity. Asthma severity we see can be classified based on symptoms and frequency. And the common symptoms that we use include wheezing, coughing, and shortness of breath. Again, may change a bit in the adolescent because we said that they will certainly have less wheezing, they may cough, but they may not complain of shortness of breath. So again, using these typical tools to determine asthma severity may fall short of what we expect. We also define, if you look at asthma severity, we also define it in terms of airflow limitations. And we talk about the numbers with the FEV1, the numbers with the peak flow. But again, I've just pointed out to you that because the numbers are, the air passage is large, the numbers may not as well pick up the readings. So you may, again, underestimate the severity of your adolescent asthma, relying solely on just symptoms and flow without recognizing that you need to shift the way you use these markers. Bronchial hypersensitivity is one of the areas I have oftentimes mentioned as I think an area that should be considered for asthma severity. It's not widely accepted, but of course, this would be also very useful in your adolescent asthma because this is the primary aspect that you're going to be seeing. So in terms of principle of treatment of your asthmatic, keen eye for symptoms, signs, and complications, extremely important, highlighting and recognizing the fact that the asthmatic adolescent symptoms shifts a little bit. You may want to confirm the diagnosis of asthma in your patient if this wasn't done before. If this was done before, then you don't need to, because once an asthmatic, always an asthmatic. But if it wasn't done before, because sometimes younger children are more difficult in terms of reliability of the formal pulmonary function testing, then it might be a time to confirm it through spirometry and methacholine. And this becomes extremely important because the medications that we use to treat asthmatics are banned substances in athletics. So they're only allowed if you get a therapeutic exemption. And therefore, you must be able to demonstrate and to complete to show that your athlete or your student definitely has asthma. And this is going to require objective testing, either through spirometry or methylcholine challenge. Once you have diagnosed asthma in your adolescent, whether newly diagnosed or a continuity of care, then of course we pointed out in the GINA that you commence treatment consistent with the severity of the asthma, arrange for continuation of care, and of course seek out confounding or contributing medical issues which may negatively impact asthma treatments. And these often include allergic rhinitis or rhinosinusitis, gastroesophageal reflux disease, and of course, obstructive sleep apnea is being shown more and more now to also be a significant aspect of poor asthma control and something to be that we need to look out for. This is the GINA guidelines again, and highlighting that once you have asthma, you start your treatment, whether you start at step 1, 2, step 3. Basically, it's based on the severity of the asthma. So you must determine the severity of your asthma, and asthma severity determination, I'm highlighting, may be different in an adolescent versus a younger child, because a younger child is going to have predominantly airflow symptoms, while the adolescent is going to have predominantly bronchial hypersensitivity symptoms. And you have to recognize that so that you can treat them appropriately. So in summary, asthma persists from late childhood into adolescence. The impact on patient based on symptoms may decrease and give a false sense of security and a false sense of resolution of the asthma. Symptoms may change from airflow-driven symptoms to bronchial hypersensitivity symptoms. Importantly, adolescence is one of the most important period of time for physical and academic accomplishment. And therefore, we must recognize that anything that would interfere with this, we must put a stop to it. And therefore, it is very important that we recognize and pick up our asthmatics, that we appropriately diagnose and treat them, and that we have appropriate treatment ready for them to match the level of severity that they have. That's what I'm going to say on asthma. I'm going to move on to obstructive sleep apnea. So when we talk about obstructive sleep apnea, just to get some terminology out of the way, so we talk about apneas, hypopneas, and the apnea-hypopnea index. And apnea refers to a cessation of or near cessation of breathing for approximately 10 seconds while the person is sleeping. That is why we're doing their sleep study. Hypopnea refers to a reduction in airflow of at least 30% for 10 seconds during this period of sleeping. And of course, we talk about the apnea-hypopnea index, which is the number of times this would occur within an hour. Under normal circumstances, we consider apnea-hypopnea index less than 5 as to be within normal, and an apnea-hypopnea index above 5 as being abnormal. The result of the interruption in breathing, that is either the apnea or the hypopnea, results from partial or complete pharyngeal obstruction during sleep. And emphasizing again that sleep apnea is a sleep disorder, although it has impact in wakeful periods. Typically, there are multiple episodes of these apneas and hypopneas, and this creates so-called sleep fragmentation. That is, periods where persons can no longer stay into deep sleep, which is when most of these episodes occur during non-REM, stages 3 and 4 sleep, and also during REM sleep. They are associated with oxygen desaturations, when episodes when your oxygen level may go very low. And one of the things that we certainly have not investigated yet, and it's wide open for investigation, is the impact of these desaturations and on long-term memory. So we do know that sleep apnea is associated with memory impairment. That is established. We do know that sleep apnea is associated with, or sleep is associated with periods when we store memory, and therefore starving the brain cells of oxygen during a period of memory storage can have a significant impact on long-term memory. So this is the memory that you store when you go to class today. You remember what was said, or you might even remember what is said now on this talk. And then tonight is when you're going to process that data to store it so that you can remember it next week and next month. If you don't get proper sleep tonight, you will not be storing the information I'm telling you today. And of course, we talk about daytime sleepiness. Now, sleep disorders are fairly common in adolescent age group, and a wide range of sleep disorders for that matter. So insomnia is one of the very commonest causes of sleep disturbance in the adolescent age group, brought on by various things, including the social networking. I remember many a night when I would get up in the night just to make sure the house is secure. I'm seeing the light on in my children's room. And when I go there, I assume that they're fast asleep because they went in long before me. I know they're on social media, they're playing games with their friends and so on. So significant impact on their sleep and causing to some extent sleep insomnia, causing insomnia, of course, but also causing sleep deprivation, both of which can lead to daytime sleepiness. And of course, there's obstructive sleep apnea, which may also occur. I'm just going to stick this in at this point just to highlight that a person can have more than one sleep disorder at the same time. So a child can have, features of insomnia associated with obstructive sleep apnea at the same time. So recognize that sleep disorders are not, you don't have one sleep disorder at a time, you can have actually more than one at a time. So if we just quickly review sleep staging, we said sleep divided into non-REM, which is a bigger part of sleep, and REM sleep. We have stages 1, 2, 3, and 4. In non-REM sleep, stages 1 and 2 are basically stages where you have some degree of muscle tone. So some of you might be in stage 1 now or stage 2. Stage 3 and 4 is when you're going to deep sleep, and that's the sleep you really need to rejuvenate your body. The numbers there are mixed up. So stages 3 and 4 sleep would be 45 to 55% of your sleep. Sorry about that. And then you have REM sleep, which is oftentimes broken up into little episodes throughout the sleep period, estimating to be somewhere in the region about 4 to 6 episodes of REM sleep for each sleep cycle throughout the night. Now, when you go into deep sleep, stages 3 and 4 sleep and REM sleep, there's relaxation of the pharyngeal muscles, resulting in upper airway obstruction, and then that sets up the issue of difficulty breathing, hypoxia, and so on. And here is the diagram demonstrating the airway open when you're awake and when you're just beginning to fall asleep. And then, of course, when you go into deep sleep, for those who have sleep apnea, there is an obstruction at the back of the oropharynx, which interferes with airflow. If the blockage is partial, you get snoring. If the blockage is complete, there is no sound. So usually for patients who snore, the snoring is commonly associated with the hypopnea, and the sudden pause in snoring is oftentimes due to the apneas. And you can use that to tell what's going on sometimes if you're listening to a bed partner sleep. Obstructive sleep apnea, we know, are associated with a number of medical issues, and these medical issues also include the adolescent population. So untreated obstructive sleep apnea is associated with increased cardiovascular risk, including arrhythmias and tachyarrhythmias, atrial fibrillations, and so on, increased risk of stroke and hypertension, and of course, long-term increased risk of diabetes. So it's very important that we keep an eye out for sleep apnea and treat it where test for it and treat it where we suspect it. So in the adolescent, of course, the issue we're going to have is how to recognize sleep apnea. Well, a number of things to look at. One, if they have trouble focusing at school, we have to look at why that is so. There can be many reasons. We have heard of emotional reasons already, but also there can be other physiological aspects to it, whether they're not getting sufficient sleep at night and getting poor quality sleep. The issue with sleep apnea to recognize is that patients with sleep apnea oftentimes will have sufficient hours of sleep. The problem is the quality of sleep is poor, so that even though they are committing sufficient amount of hours to sleep, they're still awake tired the following day because of the quality of the sleep is poor. So it's important to recognize that it's not just the number of hours, it's the quality of sleep. So the adolescent may have issues with processing and remembering and understanding. They may be falling asleep in class. They may even have mood swings, behavioral changes, poor academic performance, and interpersonal problems with their peers and family are some of the things that may suggest a possibility of, certainly it suggests a possibility of an underlying problem. And we have heard of emotional issues, psychological issues, and of course, there could be some physical aspects to it. So as part of clinical evaluation, we look at their sleep time, time devoted to sleep. We look if they have things disturbing their sleep, things like nocturia, do they get up in the night to pass urine? We look at weight changes. Again, we pointed out that adolescents in the physical get an increase in size, they get taller, but some also get stouter and fatter as they eat more and more. So they may end up with obesity and may also develop sleep apnea. As part of the evaluation, we do a physical examination looking at weight issues. We also have to look at endocrine issues, hypothyroidism, cortisol-related adrenal issues. These are all problems or underlying issues that may contribute to the development of sleep apnea as one of the complications of the underlying issue. So we do need to look for the underlying issue. Oropharyngeal issues also in terms of anatomy may also contribute, and also neck size. As part of the investigation for these patients, because oftentimes they do present with some form of daytime sleepiness or tiredness, we will of course have to exclude things like anemia, especially in females who may be menstruating and therefore run the risk of having anemia. And anemia can make you tired and sleepy throughout the day. So we do a full blood count. We look for, of course, diabetes as a contributing factor. We do their blood chemistry, thyroid function, look for any endocrine issues, and may also do their liver function. So in terms of sleep apnea, the diagnosis is based on a sleep study or polysomnogram. For a polysomnogram, we do EEG monitoring, so we can tell the different stages of sleep. We look at ECG, so we can pick up cardiac arrhythmias. We monitor to see if there's any other sleep disorder that's going on. In other words, not just specifically for sleep apnea. And to see in a setting we normally do the sleep study in a setting where if there are complications, we can always deal with it. So for ideal cases, it's preferable to do it in a sleep lab, although one can sometimes use screening tools in terms of looking for the possibility of sleep apnea. And then if one sees sufficient evidence of it, you can go on to do a formal sleep study.
Hi, Doc. We have 2 minutes left.
Sure. So these are some of the things we monitor in a polysomnogram. We said the EEG, the EOG, the eye movement, the EMG, airflow to the nose and mouth, monitor oxygen saturation, we monitor carbon dioxide in the blood. And as part of the test, we do a titration or treatment aspect to look at if they had sleep apnea, what would be the best treatment for them. If we do a polysomnogram, we can confirm the presence of sleep disorder, yes or no, and we can determine if this sleep disorder is obstructive sleep apnea or not. We can determine the severity of the condition because that impacts treatment options that are available. And we can look for associated issues such as the degree of the hypoxia, presence of hypercapnia, presence of arrhythmias, and mouth breathing, all of which impact how we actually treat the patient. So these are also secondary issues that we look at, but they have important aspects in terms of the treatment arm for sleep apnea. For sleep apnea, the options are non-invasive positive pressure support, either through CPAP or BiPAP. One can use dental prosthesis in certain situations, especially mild sleep apnea. And of course, surgery can be used for mild or moderate sleep apnea, but there are some issues with that, but it certainly is a treatment option. Having diagnosed sleep apnea, you have to ensure that you do some follow-up. We have to look for compliance. We have to look for if the treatment that we're administering is achieving the objective of keeping the person awake and alert in the daytime. And of course, over time, treatment modifications may be required to suit the circumstances. So in summary, sleep disorders are common in the adolescent population. Sleep apnea is one of the common sleep disorders, not the most common, but it's certainly one to be aware of. Undiagnosed or untreated sleep apnea, that is, may result in poor academic performance and missed opportunities. But we do know that if we treat sleep apnea, we can prevent these complications and, of course, avoid some of the issues associated with it. Thank you for your time, and I'll be around for questions later.
Thank you so very much, Dr. Paul Scott. And we are just awash with the information and the handy tips. Can you imagine? We have to tell our parents now, your son, that fat neck is giving him sleep apnea. Wow. All right, so we're going to move right along. Are we having the sponsors presentation now?
Yes, we are.
Right ahead.
H2K Vitamax Multivitamin and Mineral Syrup 200 milliliters. It boosts your immune system, enhances your appetite, boosts performance, increases energy levels. A good supplement during pregnancy and lactation. It's delicious, nutritious, complete, and sugar-free. Vitamax is a complete supplement for the whole family from age 1 year to 100. Vitamax provides 11 of the daily essential vitamins plus minerals our body needs. Vitamax is carefully designed with optimal performance of your body in mind. In highlighting L-lysine, an amino acid, it's a building block of protein, an essential amino acid that improves calcium absorption, promotes wound healing, boosts fat loss, promotes our immune system response, helps to slow the aging process, improves hair appearance, smooths the skin and reduces wrinkles, and helps to improve appetite and maintain health. H2K Vitamax, the complete supplement for ages 1 year and older.
Back to you, Doc.
Great. And it gives me great pleasure to introduce my friend, and we share the same alma mater, Dr. Jacqueline Campbell. She is well-known family doctor, pharmacologist, lecturer at the University of the West Indies, and also a practitioner of complementary and alternative medicine. We know her also as a newspaper columnist, co-host of radio programs, and did you know she's an author of the book, A Patient's Guide to the Treatment of Diabetes and Mellitus? And who better, therefore, to tell us about the management of diabetes and obesity in the adolescent? Jackie, go ahead. You have slideshow.
I'm on. Good afternoon, Pauline. We know each other long time. Thanks for that introduction. Good afternoon to colleagues, and thanks to CCFP for the invitation to address the colleagues on the topic of the management of diabetes and obesity in the adolescent. So for the purposes of definition, the World Health Organization defines an adolescent as a young person in the second decade of life. That's between 10 and 19 years of age, and has been said before that this is quite an interesting period of life for persons, in that you have the physical and the psychological and the social changes which occur. Now, to get right into the topic, adolescent obesity. It's a growing health problem, and it affects young people from all income countries you can think about, low income, middle income, and high income countries. Now, I wanted to bring to you the attention of this particular paper on Jamaica. And it says here that overweight and obesity prevalence in adults increased from 43.8% in 2000 to 55.5% in 2016. What is interesting is that in children and adolescents, we're looking at age 10 to 19 years, the prevalence of obesity has actually doubled between in the same period. So in 16 years, between 2000 and 2016. And it goes on to say that the prevalence of overweight and obesity in children and adolescents increased from 5% to 11.4% in that period. And this is really just a graphic representation of what I just said. So, it shows you that everything is going up. Now, when we look at this particular paper, it is saying that obese, something that we have been saying from a long time, obese children and adolescents are more likely, and it says here 5 times more likely to be obese in adulthood than those who are not obese. And around 55% of obese children go on to be obese in adolescence. And of course, 80% of obese adolescents will still be obese in adulthood. So we see that the pattern will continue. Again, we're looking at the Jamaica Health and Lifestyle Survey, which showed that about among the 15 to 74-year-old group, the prevalence of diabetes was approximately 10%, and this is up from 7.8% in 2007. So I hope you're seeing the pattern here. And this goes on to basically say the same thing. What we know about diabetes is that it's a major public health problem, and the progression is associated with numerous complications. Now, I found this paper, which is, it just summarizes things very well, in that childhood and adolescent obesity is a strong predictor of adult obesity. Yes, it is also a significant risk factor for type 2 diabetes. And we know that this association between obesity and type 2 diabetes, it's referred to as diabesity. And diabesity can be associated with numerous comorbidities ranging from hypertension, obstructive sleep apnea that Dr. Scott just spoke about, fatty liver disease, and so on. But what I want us to focus on is that these comorbid associations of diabesity can lower the quality of life and may shorten the life expectancy of this generation of children. So we know that this is a major health problem all over the world. And we're in Jamaica, it's a major health problem in Jamaica. Now, when we look at diabetes management, we'll have to look at education, dietary modification, exercise, self-monitoring, everything you see in here. Smoking cessation, stress management, and of course, the pharmacological interventions. Now, the goals of therapy in diabetes, we know that we need to achieve some things. The fasting, blood sugar less than 6.1, resolution of all the symptoms, the polyuria, the nocturia, the polydipsia, healthy body weight, I'm getting to all of that. And of course, maintenance of healthy levels of lipids and blood pressure. And very important here, participation of the whole family as a unit. Now, when we look at the treatment of the adolescent type 2 diabetic, we're looking at diabetes education and lifestyle changes, pharmacologic therapy, and we're gonna have another slide with this in a little while. And of course, then the lipid lowering agents, blood pressure medications as necessary. We have to emphasize the improvement of all of these things, hypertension, dyslipidemia, blood sugar levels, weight management, the prevention of short and long-term complications. We're gonna have to ask the persons to monitor their blood sugar levels 2 to 3 times per day. Problem there. Evaluation of every 3 months at the diabetes clinic, and of course the HbA1c levels. We know this has to be done. We know that we also have to monitor microalbumin levels, fasting lipid levels. So many things need to be done, dilated eye examination, and of course, neurological evaluation and blood pressure evaluation. Now, when we look at adolescent, so the principles of the treatment of adolescent obesity, as has been said before, the adolescent individual is actually is like if we remember when we were adolescents, it's like you feel that you know everything about the world, but at the same time you really don't have the necessary experience to make decisions about yourselves. But the little challenge with adolescent obesity management is that we have to have strategies which are going to rely on active participation of these individuals, and this reliance on active participation is going to be more than, say, when this individual was a child. And we have to recognize the emerging autonomy of the patient. And this is the challenge treating, I would think, any disease where adolescents are concerned. Now, when we look at the management of adolescent obesity, we have to assess and manage obesity-associated disorders. We have to look at dietary changes. We have to support long-term behavioral change, increase physical activity, decrease sedentary behaviors. This has been alluded to or spoken to about, I should say, by Dr. Leiber, increasing the screen behavior. We have to think about improved sleep. Dr. Scott spoke about this. We have to think about strategies for long-term weight maintenance. We may have to consider pharmacotherapy, consider bariatric surgery. Now, this slide here on the treatment of adolescent obesity, if you focus on the part that I've highlighted there, we have to think about things like, sure, we have to think about the lifestyle factors. What are these individuals eating? Beverage consumption, which we're going to speak about in a little while. Family routines around food and eating. Snacking, for example. Physical activity. How does this person go to school? So the importance, are you walking to school? Are you taking the bus to school? Or are you being driven to school? Sports participation, family activities, the sedentary behaviors which I've referred to before, the screen time per day, because more time spent on a computer or the tablet or the phone is going to equate to less physical activity. There is this meme I saw where Santa Claus was breaking into the house, not breaking into the house. Santa Claus is actually going into the house through the chimney. And Santa says that it's easier to get into a house now than before. And the reason is that it's everybody on the tablet, not paying any attention to Santa. So some of the things that we have to consider in terms of behavioral change techniques for the adolescent, so the obese adolescent, we have to think about goal setting, performance goal setting. For example, here, I will get an extra half hour of physical activity into my day. I will do this by catching, well, we don't have any train as such in Jamaica, by catching the bus to and from school instead of asking my parents to drive me. I'll ask my friend for company to go to the gym. You have to think about goal setting, outcome goal. So you have to think about specific weight loss goals, and this has to be developed in consultation with a therapist, a nutritionist, because it's no sense saying to somebody, well, you know, you have to lose weight. This person has to be told, this is how much weight would be ideal for you to lose and how to go about losing the weight and maintaining the weight. Self-monitoring. How does the person monitor himself or herself? Recording of the physical activity. You can, for example, suggest that the person uses a pedometer. Daily recording of screen time, daily recording of eating habits, weekly recording of weight, or I would tell people measurements. Stimulus control, very important. Television, laptop, cell phones, other mobile devices are out of the bedroom at night. So when you go into bed, it's for you to go to sleep. Parent and the children agree not to store unhealthy foods in the house. This is very important there. Parent agrees to serving evening meal using smaller size plates. So things like that. So you think about it, it's all very challenging. So these persons have to follow this daily plan they have to follow this complex set of behavioral action, meal plan, physical activity, taking medication. So you can see that this is setting up quite a problem for a number of persons. So what are we going to be looking at now? So as I would say to my students, we're going to begin the lecture right now. So the goals of management. So the goals of management would be to prevent or delay the onset and progression of complications of diabetes and obesity. So in terms of goals of management, we're looking at normal. Normal is a good word. So you want normal blood glucose levels. Emphasize with the diabetic persons, whether it's adolescent, in this case, it can be an adult. If your blood sugar level is normal, it means you're avoiding the high and low blood sugar levels, both of which are potentially harmful, can send you into a diabetic coma, which can be fatal. You have made the point. We're looking at not just a normal blood glucose levels, we're looking at normal blood pressure, normal cholesterol, normal kidney function, and normal weight. Objectives here would be normal body mass index. So we have to, well, work out for this individual what is the current body mass index and where we would like this person to be. We have to guide this individual in terms of meal planning, healthy food choices. You notice I didn't say diet, because diet sounds sort of to me short term, or it sounds like you're going to do something just for a specific, well, short term, just for a specific period of time, And then afterwards, you can go back to what you were doing before. So I prefer the term meal planning, healthy food choices, physical activity, and behavioral therapy. Lifestyle changes, which everybody is familiar with. When you look at the lifestyle changes here, I want us to look at smoking cessation. Let us not fool ourselves. Adolescents smoke, as Mrs. Curlew mentioned, they will smoke. So we have to ask them what they smoke and how this will impact or how this may impact their health and the reason why they should stop it. Reduction in alcohol intake. Many young people are drinking alcohol and other substances. Why is it important for them to reduce their alcohol intake, to stop their reduce or stop drinking alcohol? So ideally, I stuck this in here, ideally the management of diabetes in this age group should involve an endocrinologist, diabetes nurse educator, nutritionist, and a behavioral specialist. That's ideal. But the fact is that we're looking at us as family physicians and we have to do many of these things. So first, I'm going to start with education. Keep it simple. So when we look at patient education, we already know that this is an essential component of the treatment plan in diabetes. And it is a process involving not only the patient, but the family and all members of the diabetes team. Some strategies to think about, explanation and discussion about the possible causes of diabetes. This age group, we know, they want to know, why is this happening to me? As with any age group, why is this happening to me? And, involve them. Listen to what they have to say. Discussion about the need for blood glucose monitoring, because much of the monitoring may have to be done by them. Maybe the parents may be busy, not being able to do all of these things. Why is it important to monitor their blood sugar levels? Why is it important to comply with the drug regimen? We can also think of therapeutic camping. I'm not sure if it's still around, but there was one for diabetes called Camp Yellowbird a few years ago. I know COVID sort of interfered with that. And then you have the support groups. That's very important because many of the adolescents who are diabetic, who are obese, they face challenges with their peers. They may be bullied. They will feel different from the other people. And adolescents, sure, for some things they want to feel different, if it's some sort of fashion, as it were, different to a point. But when it comes to your health, you want to fit in with the others. You don't want anybody to know that you have a health challenge. So this is where support groups would come into play, very important. And of course, the therapeutic campaign. Patient education about complications. We can use, let us say, if the person has a crisis or some acute complications, we can use this as an opportunity, a teaching opportunity to say, well, reinforce the importance of self-management where diabetes is concerned. We have to educate the patient about potential adverse effects of the oral hypoglycemic agents, example, ketonuria. Patient education. We have to be mindful of the fact that adolescents, many of them are sexually active. So are they thinking about it? Let us not, hide our heads in the sand. Provide advice about contraception, genital hygiene, sexually transmitted diseases. So I was glad that Dr. Walker spoke about that. In pregnant patients, because some of our adolescents will become pregnant, emphasize the importance of good glycemic control before and during pregnancy, and of course discuss the effect of maternal diabetes on the fetus. So some practical skills training, insulin injections, again, hypoglycemia, recognition and treatment. This one that I put in red, psychosocial adjustment to the diagnosis. If we think about it, us as adults, if we are diagnosed with a particular disease, let us say we're told we're diabetic, it is going to have some impact on us. We may say to ourselves, why me? Think about an adolescent. Why is this happening? So they are going to need some help in terms of adjustment to this diagnosis. So the next thing I want to think about, which is a very, very big part, is appropriate food consumption. So a diabetic, mommy, what I must eat now? All right then. So goals of healthy eating, or healthy meal planning, you have to eat nutritious foods. What does that mean? Nutritious foods. Achieve normal body weight, maintaining your normal blood pressure, cholesterol, and so on, preventing complications. So it was last year during the Jamaica Observer Monday exchange on diabetes. Dr. Ro Porter, Ministry of Health and Wellness, she said that consuming, and this is something that we all know, consuming high-calorie foods, packaged processed foods that have a high glycemic index instead of those foods that take long to prepare, like ground provisions, are causing a challenge. They're burning out your pancreas. So we can say that, if necessary, to our adolescent diabetics. So some tips I want to share with you. One, they need to know how to read labels. Try not to tell them that they are bad foods. Understand what they're eating. I'm not going to go into details about that. Encourage balanced meals, portion control. Encourage them to select healthy options in restaurants. For example, select the junior meals. Eat the burger, not the fries or the soda. So let us start with soda. So this is a Pepsi there, and that is a cran water. Now this bigger Pepsi on the right here has the entire bottle contains 17 teaspoons of sugar. So now this bottle, which I'm going to show you, I hope that you're seeing this one here, it contains 355 mils of soda. I went shopping on Friday, and this has in 38 grams of sugar. So that, if we divide the 38 by 4, that is going to be 9.5 teaspoons of sugar. So that is what this contains. So we're going to have to educate our patients about this. So a better choice, maybe one with no sugar, but it just depends on your taste and, how much you're going to drink of this. Remember, I showed you this slide already. Portion control. So again, we're looking at using smaller dinnerware, serving the meal in a smaller plate. We can use the plate as a portion guide. This is the one we can think of. Half of the plate is veg. Quarter of the plate would be the carbs, and the rest of the plate could be the protein. Quarter is the protein. And we already know, for example, 1 serving of carbohydrate would be 15 grams. And we know that that would be like, say, a half a cup of cooked rice. It's Sunday, so people going to eat them rice and peas. Half a cup, and when we talk about cup, we're talking about measuring cup or one slice of bread. So in other words, the individual will have to be taught how to eat. Remember this already. So I found this very, very interesting. So look at Burger King. We have to think about what is available here. Burger King, Wendy's. So you look at a Burger King Whopper, it's 650 calories. So if someone goes out with their friend and they're going to have a Burger King, what you could say to this person is, yes, you can eat your burger, but what about selecting the Whopper Junior? You get what I'm saying? So you have to just work with these persons where they are, empower them to make decisions. Do not make them look as if they are going to give up their lives. So you teach them about making a healthier substitution. Eat the burger, but not the fries or the soda. Or another thing, if they want to eat, let us say, any fast food, chicken or so, they could take home the chicken, buy the chicken, and eat it with the rice or whatever is provided at home. And of course, vegetable. So you're eating what you like to eat, what you want to eat, but with healthier, sides, as it were. Burger King, small fries, contain 340 calories. Whole heap of fat there. Look at that sodium. So you have to teach persons that, okay, if you want to have some fries, don't have all of the fries. Or as I said to you, think about not having the fries. Compromise. The next thing, physical activity. Aerobic exercise, 30 minutes, 5 times per day, stretching, strength training. And with young people, we have to give them the information. Why is this so important? We know that physical activity for patients with type 2 diabetes, what it will do. And when the talk is about not just diabetes, obesity, we know that the physical activity is also going to be important in reducing weight. So what's the next step for this person? Adherence to medication. I put this here because most of us would know that type 1 diabetes requires insulin therapy, but many of our patients may not be, they know this to a point, but they want to sort of twist their arm and they want to say, well, you just can't try me with some tablets, doc. The fact is that we have to say to them, type 1 diabetes requires insulin therapy, and we have to give them the information as to why that is so. Type 2 diabetes, interesting information here is that the safety and efficacy of most of the non-insulin hypoglycemic therapies in children and adolescents with type 2 diabetes has really not been established, but physicians have been known to prescribe drugs for these, the same drugs used in the treatment of adults to treat children and adolescents. So among the non-insulin drugs currently in use to treat type 2 diabetes in adults, the FDA has approved metformin. That is metformin, liraglutide, and exenatide extended use for release for use in children. Liraglutide is one of the GLP receptor agonists. It is given, if I remember, twice per day. It is actually given subcutaneously. Exenatide extended release is given once per week. So these have been approved for use in children with type 2 diabetes. So how can we delay the complications of diabetes and obesity? Well, we think about it, it involves cooperation between the patient, healthcare providers, and we have a lot of healthcare providers here, not just the physicians, but the pharmacists, nurses, diabetes educators, nutritionists, you name it, it requires the support there. Education is going to be very important. We're looking at family support. We're looking at support from friends, support groups. Very important with the patient. A patient has to realize that if you delay complications of diabetes and obesity, you are going to improve the quality of your life. So in other words, you're going to live longer and you're going to live a better quality of life. A lot of this depends on the patient's mindset. So the mindset, it depends on the individual, but that mindset has to be influenced by the family, the healthcare professionals, and of course, the various support groups. And of course, the relationship that this person has with food is going to be important. You notice I said relationship with food is very important. The relationship with your physical activity, how you are viewing your body, that is going to be very important. So the take-home message here is in terms of the objectives of management of diabetes and obesity in the adolescent, we have to think normal body mass index. We have to think about meal planning, healthy food choices. We have to think about physical activity. And so many times we're thinking normal BMI, food, we're thinking physical activity. But I put it to you, my colleagues, that we have to emphasize how important behavioral therapy is. Very, very important. We cannot forget that at all. Thank you for your attention.
And we thank you, Dr. Jacqueline Campbell. Thank you so much for an engaging presentation on diabetes. We know how to explain this. All right, so we'll be inviting our three presenters in this second session to be ready for questions, but I do believe that we now have a presentation from our sponsor.
This video focuses on respiratory issues and type 2 diabetes. Control your breathing. Control your life with H2K Asabec beclomethasone inhaler 50 micrograms. Asabec is used to prevent and control symptoms such as wheezing and shortness of breath caused by asthma and also in chronic obstructive pulmonary disease, COPD. After using Asabec, improvement may occur as soon as 24 hours. However, full effects may not be felt for 1 to 4 weeks after using it regularly. Continue to use Asabec even if you feel well. Asabec does not replace your rescue inhaler in the onset of an asthma attack. Breathing is easier with H2K Bronco Air Salbutamol 100 microgram inhaler. H2K Bronco Air relieves the symptoms of asthma and COPD rapidly, usually within 5 to 10 minutes. You should keep Bronco Air, your rescue inhaler, within reach at all times in the onset of an asthma attack. When you have a wet cough, dry cough, any cough, use Dawa Cough. Dawa Cough contains 2 mg salbutamol, 4 mg bromhexine, 100 mg guaifenesin, and 1 mg of menthol. Dawa Cough is a mucolytic and expectorant plus bronchodilator, and it tastes great. Sour cough is an excellent option for the treatment of asthmatic bronchitis, acute and chronic bronchitis, nasal congestion, rhinitis, active and passive smoking, and much more. H2K Dower cough is useful in children from as young as 2 years to adults. The maximum dose is 20 ml per day for adults. H2K loratadine, a long-acting antihistamine agent with once daily dosing, 24-hour control and rapid onset of action. Non-drowsy for the treatment of allergic rhinitis, perennial rhinitis, chronic allergic rhinitis, indoor and outdoor allergies, and seasonal allergies. Get relief with loratadine as fast as 30 minutes after dosing. Available in fruit flavor syrup and tablets, 10 milligrams. H2K cetirizine, the complete response to allergies. Cetirizine is the most potent antihistamine with proven action on both early and late phases of allergy. For fast-acting allergy relief, once daily dosing, use H2K cetirizine syrup or tablets. May cause drowsiness. H2K Bore Total, the perfect herbal companion for wound healing and skin infections. Bore Total contains neem, aloe vera, licorice, sesame seed oil, zinc, and asoka. Use Bore Total to reduce topical pain, calm minor skin inflammation, treat minor skin infection, and promote healing. For the diabetic foot and minor bed sores, Bore Total moisturizes the skin to help prevent ulcer formation. It also helps the skin heal and prevent dry, cracked skin. When combined with H2K Silvercant silver sulfadiazine, you can use a mix of 50-50 with Silvercant and Bore Total, and it will work even better on the diabetic foot ulcers and bed sores. H2K Metformin 500 mg. Metformin is the gold standard in the treatment of type 2 diabetes. Metformin protects the obese diabetic with its beneficial effect on weight, its lack of hypoglycemic effects, and its positive effect on lipid profiles, leading to a reduction in triglycerides and total and low LDL cholesterol with little or no effect on HDL cholesterol. So, before hypoglycemia strikes vital organs, use H2K Metformin 500 mg. H2K Metformin XR, advancing diabetes management, formulated with hydrophilic polymer matrix technology, delivers uniform release, resulting in stable and sustained blood levels with 24-hour control. With its favorable safety profile, decreased gastrointestinal effects, H2K Metformin XR provides once daily dosing, enhancing compliance, lowering pill burden, making it more convenient for persons with type 2 diabetes. Switching is easy from regular metformin to Metformin XR. Starting dose is 500 mg once daily. Increase as needed. The maximum dose is 2000 mg once daily. Take Metformin XR with your evening meal. Thank you for listening.
So much. Although the necessary thanks will be given, I really want to thank our speakers, Dr. Leo Walker, Dr. Paul Scott, and Dr. Jacqueline Campbell. Excellent presentations, very wide-ranging from obviously experienced practitioners with tips for us to bear in mind as we work with our patients. Really want to thank them for their interventions and their wise words. We're going to answer questions now. I am looking at the question and answer, and the first question is for Dr. Walker, who, when you answer this, after you've answered this question, you could probably say a little bit about the herpes infection, herpes simplex. Dr. Walker, are you on? The question is, what is the treatment for chronic persistent vaginal fungal / yeast infection, particularly when it occurs before and oftentimes after the menses. We see this a lot in practice, don't you? Dr. Walker, are you able to comment on this?
Yes, I'm here. So there's an important distinction in women who have the onset of vaginal irritation or inflammation prior to the onset of menses. That may not actually be a yeast infection. What that may be is what we refer to as cyclical vulvovaginitis. And it occurs as a result of a progesterone-induced dermatitis. The differentiating feature is once the period happens and it's finished, the symptoms tend to resolve. So it is something which is cyclical, it's something which resolves without therapy, and it's often not associated with that characteristic cottage cheese discharge. What is more common are recurrent yeast infections following menses, and this is really because the menstrual blood can sometimes disrupt the vaginal pH and lead to further proliferation of that Candida species, which can colonize the vagina and is asymptomatic in 20% of cases until there's an environment which is now suitable for further growth. So for those patients, we usually employ a little bit more aggressive therapy. We often start what we call azole induction therapy. Sorry, let me just... Right, so we often start with azole induction therapy, where patients are administered fluconazole, 150 milligrams PO, as 3 doses, 72 hours apart, and then they are maintained on fluconazole 150 milligrams weekly for a period of around 3 to 6 weeks. What that helps to do, it not only treats the Candida species locally in the vagina, but it also addresses Candida albicans, which may be colonizing the gut, which is often a source of these recurrent episodes. Hello?
Sorry about that. Andrea, please mute. Go ahead, Dr. Walker.
Sorry, right. So there's also the use, particularly for patients who have recurrent infections, of boric acid suppositories, which can be used for the 600 milligram suppositories for 2 weeks consistently. What has been shown is that it improves the vaginal pH and therefore reduces the susceptibility for recurrent infections. So it's really both azole induction and maintenance therapy, as well as through the use of boric acid suppositories.
Thank you. That was pretty comprehensive. Want to say a little bit just quickly about the herpes infection, then we go on to questions for the other presenters.
Absolutely. HSV, both 1 and 2, are among some of the more common infections which can affect both the oral and the genitalia of both male and female patients. Largely, there are studies that have been done, most notably in New York, which actually show that 70% of individuals who are HSV positive actually had never experienced an outbreak and remain asymptomatic. So it is one of those infections which individuals can remain asymptomatic for a very long period of time. It's often associated with those characteristic vesicles, usually multiple. The primary outbreak often associated with significant pain, irritation, or burning to the genitalia, as well as significant dysuria. Those outbreaks tend to last for around 10 to 14 days, but the duration, the frequency, as well as severity of the outbreak can be significantly reduced through the use of antiviral therapy, most often acyclovir as well as valacyclovir. It can be associated with a scant vaginal discharge as well as lymphadenopathy. But the important thing is what we recommend is yearly STI screens, which often includes HSV, since such a vast majority of patients can be asymptomatic with the infection.
Right, thank you. Somebody wants you to repeat the azole treatment, but I'm going to ask you to write the answer in the Q&A for me, Dr. Walker, so
Sure,
we can go on to other questions.
That's fine.
All right. We have an anonymous attendee who wants to know, do we need to report do we need to report adolescents who are under 16 to the CPFSA when they inform us that they're having sex or present with an STI? And this person is very concerned because, of course, the Data Protection Act does have some implications here. This is to anyone in the panel. I'm not sure, but could Dr. Walker, if you like.
This would have been for Miss from CPFSA, but she has left, I think, because she has another engagement.
All right, that is fine. I think we'll have to bear this in mind. Just at this juncture, let me tell you, this exciting adolescent seminar is only part one. We're actually going to have a part two on January the 25th of 2024. So please mark your calendars or diaries if you have them as yet, that January 25th, CCFP will be having part two of this adolescent seminar series. All right. Somebody is asking, even as Doc is writing, they're really interested in your treatment for patients who present with, persistent candidiasis. So I think probably we should say something. I wanted to ask Dr. Scott, though, if I may, about the patients with obstructive airway, obstructive sleep apnea, whether or not the STOP, S-T-O-P, BANG, B-A-N-G, mnemonic applies to them, to teenagers, and in particular, the suggestion that you could measure the neck circumference, and if it's more than a certain amount, along with the history of snoring, consider sleep apnea. Dr. Scott?
Yes, certainly you can use a number of screening tools that are available also to screen for sleep apnea. In terms of, you have screening tools in terms of sleep disturbance, you have screening tools in terms of sleep apnea. Yes, it can apply for adolescents also, but one of the things I wanted to highlight as it relates to the adolescent is that as, I guess as parents, but also as practitioners, I guess most of us are both, recognize that the adolescent presentation of some of these things may be quite different. And so we have to be on the lookout for these presentations. So, I mean, I'm using to a large extent my own experience with my children. Certainly when they were in their teens, they would come out of the room at odd hours looking tired and so on. And to a large extent, they didn't have sleep apnea in my case. They really just didn't go to bed. They stayed up with social media and so on. So, that's a common problem that we face. And I even went as far as at one point thinking of having a special committee formed of parents of boys, because I found it's far more prevalent in adolescent males than with the girls. The girls are more likely to go to bed. The boys are more likely to stay up late playing games. But yes, all the common tools utilized are the traditional tools for screening for obstructive sleep apnea and excessive daytime sleepiness are quite relevant for adolescents. That's it from
Thank you,
me.
Doctor. Yes, thank you. Dr. Walker, keep writing. There are other questions there. Dr. Campbell, diabetes. How do I explain this to parents? Not well, to the patient. Diabetes sounds like a double whammy,
It's a term which was coined many years ago by Americans. It's a combination of persons who did the term obesity in a type 2 diabetic. So it's really just a term. It's really just a term, diabetes. But I like it because it sums up what is happening with the person quite nicely. And also we can see that there is a strong association between the two conditions and also the complications thereof. It's very, very important. So I just like the combination, the term diabetes. Mhm.
I think we've had a fabulous seminar, part one, first session with this focus on mental health, and this second session, which is very important, issues that we face. I don't think so. And Dr. Walker has answered the question in writing, so you can all write down how to treat resistant or persistent candidate. Go to the vote of thanks, which is going to be presented or given to us by Dr. Purai, and she will close off the session. I thank you for having me as moderator. Dr. Andrea Purai, please.
Good afternoon, everybody. Not hearing you. Okay.
Hi, Dr.
We
Perry.
can hear you.
Okay. Okay, so good afternoon. Start my video now. Okay. Right, so good afternoon, all. It's my privilege to have been asked to offer a vote of thanks on this occasion. Let me first begin by giving glory to the Almighty God for making today's occasion result in success. I, on behalf of CCFP, extend a very hearty vote of thanks to all speakers for taking the time off to share their knowledge with us today on adolescent health and STI webinar part 1, optimizing adolescent health. First and foremost, a big thank you to Dr. Jordan Sr. for giving us an excellent, informative, and relevant coverage on recognizing and managing common adolescent mental health disorder and the need for increasing screening, and when in doubt, feel free to refer. Further, we are grateful to Dr. Judith Leiber for sharing her knowledge on impact of social media on adolescent health and mental well-being, and advising us about the communication is important when dealing with adolescents, and to advise the parents about the 5-to-1 rule, 5 minutes of active listening and 1 minute of talking. We'd also like to express our sincere thanks to Mr. Colette Curlew for a clear and detailed presentation on substance abuse and addiction, identification, intervention, and referral, and also emphasizing the need to screen children for substance abuse, especially those in grade 10. And we'd like to acknowledge our gratitude to Dr. Paul Scott for an informative and practical presentation on allergens, allergies, asthma, and sleep apnea, and telling us more about that sleep apnea is a common sleep disorder among the adolescents, and undiagnosed and untreated may result in poor academic performance. In addition, we're grateful for Dr. Leo Walker for an excellent performance on his presentation on adolescent reproductive health, STI, endometriosis, and refreshing our memory and management of treatment of sexually transmitted disease and endometriosis in adolescents. We'd like to express our sincere thanks to Dr. Jackie Campbell for giving excellent coverage on management of diabetes and obesity in the adolescent, and stressing the importance of the practical skill training, especially the psychosocial adjustment to the diagnosis, and the importance of behavioral therapy in their management. We are all inspired by their great works and words. We are grateful and thankful for the sponsors, Abbott Nutritional, Health 2000 Canada, Indus Life Science. Thank you, sponsors, for making the CCFP STI Adolescent webinar a successful today. I take this opportunity to thank the technical personnel, Mr. Harold Sam, for rendering his time and expertise to making this webinar a success. I would like to thank Dr. Dane Levy for gracing this day and bringing God's blessing upon each of us and making this day a memorable one. Also, I'd like to thank Dr. Seni Onoju for doing welcoming, greeting, and organization of this event. The moderators, Dr. Arno Brown Martin and Dr. Pauline Williams Green, you were absolutely outstanding. You did an excellent job. And again, I cannot tell you how much contributed to the success of the CCFP Adolescent Health and STI webinar and how much we appreciate your willingness to do this. A conference like this cannot become successful with a single person. Therefore, I extend a big thank to you, all the persons on the CCFP team, especially Dr. Seni Onoju and our secretary, Ms. Lynn Thompson-Hyatt, who are motivated and dedicated colleagues with a willingness to take on completion of tasks beyond their comfort zone. We all can agree it was a informative day. Finally, we thank you, my audience, and my friends, a total of 225 attendees, for your attention, contribution, and cooperation in making the CCFP Adolescent Health and STI webinar Part 1 a resounding success. We'd like to thank you again for being with us and making this event a success. It was a magnificent Sunday morning and afternoon. Thank you very much. If anyone wants CME, the cost for a CME is $1,000 for 5 CMEs. We all know that registration is free. And remember, as Dr. Williams Green said, on January 25th, 2024, we all welcome you to the Adolescent and Health and STI webinar, Part 2. Thank you very much again. Stay safe, healthy, and have a great Sunday. Thank you all. Back to you, Sam.
Good day from Health 2000 Canada, otherwise known as H2K, a generic pharmaceutical company proudly serving you since the year 2000. I will be highlighting drugs available for sexually transmitted infections,